Okay, I'm going to kick us off. I want to welcome everybody to this course that we've called You Have a CBCT, What Now? How to Maximize Diagnostic and Financial Use. We've put a lot of work into this, a lot of preparation, and we're really excited to kind of dive deeper on the importance of your CBCT and how to use it and how to maximize it. And we've got just a stellar presenters and instructors here, and rather than me botch these wonderful people's biographies, I'm going to have them just briefly introduce themselves, and then I'll kind of run through the agenda on how we'll attack this course. But let's start and kind of round robin. We'll start with Dr. Siegel, and then we'll go to Garry, Carneal. And then I'll introduce Dr. Brown and myself, and then we'll go to Christine Taxin. So we'll start there for introductions.
Great. Thanks, Caleb. Just briefly, my name is Dr. Eliot Siegel. I am a professor and vice chair of radiology at the University of Maryland. And I'm also in charge of radiology and nuclear medicine for the VA hospitals in the West Virginia, Washington, D.C., and also Baltimore area. I do a lot of research on all things related to image quality in radiology, and do a lot of research on cutting edge digital systems, including artificial intelligence applications. I have the privilege of being the head of the standards committee at RadSite, and also the Chief Strategy Officer. So it's great to have the opportunity to be on today's call. Thanks.
And I'm Garry Carneal. I have also the privilege to serve as the president and CEO of RadSite. Both Dr. Siegel and I have been with RadSite for over 10 years, and it's been a real honor to be part of its accreditation mission. I've spent most of my career focused on the development and implementation of accreditation programs in healthcare. In fact, I have brought 26 accreditation programs to market over the past 26 years. So as you'll hear in a minute, we've really spent a lot of time focusing on how to create a best-in-class experience in terms of accreditation, and we're looking forward to explain to you a little bit more about the importance of this, at least the Cone Beam CT accreditation program. Thanks, Caleb.
Yep, you bet. And you heard from me just a second ago, but Caleb Manscill, CEO of DentalRay, and DentalRay is a company, we'll talk about it in just a minute, but we do radiology interpretation for dental offices and dental specialists. And I've been involved in the dental industry for over a decade and a half. Work with thousands of practices through different technologies. And then I'll introduce Jacob Brown, who will be on in just a minute, but Dr. Brown is a neuroradiologist. He's our chief medical officer as well. Did some of his schooling out in San Francisco and in other areas around the nation. But we'll hear from him in just a moment. And then Christine, I'll have you introduce yourself last, if that's okay.
Hi, I'm Christine Taxin, and I work with codes. So boring compared to everybody else, but I can say that knowing the codes will help you make money with your CBCT scan. So I'm honored to be part of this organization that we have worked so hard to put together. And it's just a story of people understanding that teamwork will help your team be successful. So I want to thank you very much for being here and allowing us to present the different parts of your business. So thanks.
Thanks, Christine. Okay, well, before I hand it off to RadSite, let me just kind of section off how we're approaching this. We're really focusing on 3 sections of how to maximize your CBCT. And the first thing you're going to hear from is RadSite, and they're going to talk about accreditation, and they're going to talk about how to set up your CBCT or the modality that you're using so that you can get the most out of it. And then we'll move on to how to approach interpretations. And Dr. Jacob Brown will take you through kind of the process that he runs through if you're looking at interpreting these CBCTs, and then what to think about, what to look for, especially outside the oral cavity. And then lastly, Christine will kind of bridge into that, and she'll take that interpretation and give you an example from a medical billing perspective, how you can pull out some of the codes and submit those for medical reimbursement. So with that said, and sorry, one more thing before I hand it over to RadSite. If you have any questions, feel free to chat those in. We'll take them through chat. Me as the moderator, I'll kind of engage the different presenters and ensure that we're answering your questions. We may answer it right in line with the presentation, or we may hold until the presentation is done or the portion of the course is done. But we'll certainly answer all of your questions. So with that said, we'll pass the time over to Garry and Dr. Siegel to start.
Great. Well, Dr. Siegel and I are very much looking forward to sharing with you some of the insights that we've garnered over the past 4 or 5 years. We actually took about that amount of time to develop the cone beam CT standards, and we'll tell you a little bit about our journey together. But we're so thrilled that about a year ago, we were able to launch our both dental and medical cone beam CT accreditation program that's been approved by CMS. RadSite is a volunteer-based accreditation organization. We have a pretty dynamic leadership, as you can see on the screen, including Dr. Siegel and myself. In addition, we are run by a committee, a system of we have a standards committee for the traditional advanced diagnostic imaging. We have a standards committee for cone beam CT, and then we have an accreditation committee. So it's really this collective knowledge base that really helps us succeed. The committees are made up of a variety of different stakeholders from the healthcare industry, which really gives us a kind of multi-dimensional perspective on things. RadSite's actually been around for the better part of, well, it looks like we're closing in on almost 20 years. It was originally established to help payers and states like New Jersey to develop a certification program for both high-tech and low-tech accreditation. In fact, we actually have accredited or certified 60,000 pieces of equipment at 25,000 different locations. But in 2010, we decided to focus exclusively on advanced diagnostic imaging, at least thus far. We became a separate company in 2010 and began developing the accreditation programs for traditional CT, MRI, and nuke med, which we first launched in 2011. And then we finally secured the CMS recognition in 2013. And over the past 5 or 6 years, we've also secured 350 private payer recognitions. And we continue to tweak our standards. And as we're going to talk about, we're going to focus mostly on the dental cone beam CT accreditation programs, again, that were launched about a year ago. And we actually announced the first wave last fall. And I'm pleased to report we just issued our 1,000th accreditation after of imaging systems. So that's quite an accomplishment for RadSite. And our cone beam CT business is growing rapidly. You know, it's interesting. We have a rich tradition in the United States of accreditation, and you often think of the Joint Commission, for example, for hospitals, NCQA for HMOs, CAR for certain, skilled nursing facilities, et cetera. And we're so excited that we can help fill this gap in terms of this accreditation tradition, which can help develop national standards. About 5 years ago, for example, I was hired by the American Telemedicine Association to actually develop to take their initial accreditation programs for telehealth and expand and improve upon it. And on that journey, obviously prior to the pandemic, the typology of telehealth telemedicine was really not clear. there are some questions about regulations, certainly skepticism by payers for reimbursement. And during that 3 to 4 year journey, we're really able to stabilize the practice of telehealth, telemedicine. I won't go into details, but really set the stage so that once we hit the pandemic, for example, telehealth, telemedicine could take off. I really feel the same way about cone beam CT. I mean, you think about telehealth, it's really about a point of care where the patient's at. And cone beam CT represents really the same opportunity in terms of the different practice areas, not only in dental offices, but for example, orthopedics, ENT, podiatry, chiropractor. This is really, and Dr. Siegel talked a little bit about the enhanced functionality you get with the 3D cone beam CT image, but it's really transformative. But the problem is a lot of times regulations can't keep up. Payers don't understand really what's going on. And that's been during the 25 other patient programs I brought to market. It's really been a pleasure to kind of provide that leadership in terms, much like the telehealth standards, to really help people understand whether you're a payer, regulator, consumer, patient, and provider, as to kind of stabilize in the basic rules of engagement. So, part of the journey is to promote that the quality, the transparency, identify the workflows as to what's associated with the emerging practice, in this case, cone beam CT imaging. Make sure certainly we're securing additional recognitions beyond CMS in terms of payers, hopefully being part of the regulatory process, creating, again, a national standard. And then, a lot of payers and others really are focusing now on value-based purchasing initiatives. I'll pause for a minute and see if Dr. Siegel, if you have any other kind of comments or thoughts regarding kind of how cone beam CT can promote best practices. Eliot, you're on mute.
Thanks, Garry. If you could just go maybe back a slide too. So I think one of the things I wanted to emphasize was the different types of cone beam CT. And so, Garry, you had put up this table, which I think is really helpful, looking at where cone beam CT actually lies within the variety of different imaging specialties. And so, we have computed tomography, MRI, and nuclear medicine, all sort of within the larger universe of specialty modules. And one important point is that there are really two different mechanisms for being able to acquire CT images. One is what is referred to in this particular table as traditional CT, and then the other utilizes a very different acquisition technique that actually takes multiple different larger images, more analogous to taking single radiographs, but it takes them at multiple different angles and utilizes a different strategy to reconstruct those images. And ultimately, we can get images that look very analogous to traditional CT. There are a number of different advantages of cone beam CT in comparison to CT. In general, doses that are used for cone beam CT are somewhat lower than in traditional CT, but that can vary significantly. Another difference is that the spatial resolution of cone beam CT tends to be significantly higher than traditional CT. So if one is looking at, really fine detail for dental applications or orthopedic or maxillofacial or other applications that require a very high resolution, cone beam CT is particularly well suited for that, given the very high spatial resolution of each of the images that are obtained by cone beam CT. When we look at cone beam CT, there are multiple different categories that we recognize within cone beam CT. By far the most common is a dental cone beam CT, which is rapidly becoming the standard for dental imaging in comparison to PanRx and other more specific imaging of the teeth, because the doses that are utilized are pretty comparable to conventional dental imaging, but having the ability to be able to reconstruct the images that are obtained and reconstructed volumetrically in multiple planes, the axial plane, which is more the traditional CT plane that most of us are used to looking at, but also being able to reconstruct in the sagittal plane, in the coronal plane, and in oblique planes gives us access to information that would be really difficult to get from conventional X-ray dental studies. Also, we've got the capability of being able to reproduce images with a 3D perspective. And also another advantage, which is also true of traditional CT, is being able to make very precise measurements. And so when you have conventional X-ray, any measurements that you make are subject to a magnification effect. And if you don't know exactly how far the patient's tooth or feature or implant or whatever is from the detector, it's impossible to get precise measurements. Whereas with traditional CT and cone beam CT, one can get very precise measurements of all of those. So, you know, it's better from a qualitative perspective, comparable dose to X-rays, and also gives one the capability of being able to do quantitative measurements and have much greater detail than one could get otherwise due to its tomographic nature. Other modalities in cone beam include for ear, nose, and throat imaging studies and maxillofacial imaging studies. Sinus evaluation would be one of many examples, but also for musculoskeletal imaging, including the knees and feet and hands, and orthopedics in general, and then of course podiatry as well. And so I'm absolutely convinced that the standard in dental imaging is going to migrate from conventional dental X-ray to cone beam CT, and we're seeing something very similar to that in X-ray imaging, in radiology in general. We're seeing more and more utilization of CT technologies, and a lot of the work that I do is in artificial intelligence, where we're looking at being able to have AI be able to enhance the images, decrease noise, and also, you know, help with regard to diagnosis. One of the challenges that we have for cone beam CT is, depending on how one does an acquisition, it's obtaining complete information. So not only the oral information, but we're also seeing base of the brain, base of the skull, we're seeing cervical spine, and all those additional features, which in general, our subspecialist colleagues are not necessarily used to seeing in the images that they've obtained. And so I'm looking forward to some of the discussion regarding the non-oral findings that one sees on this technology. But it's absolutely heading to be the state of the art, and I believe it will be the community standard moving forward. So thanks, Gary.
Sure. You know, it's really exciting to see kind of the traction that cone beam CT systems have already taken place in dental offices. Depending on who you talk to, there's tens of thousands of cone beam CT systems already been installed, as many as 50,000. And then on the medical side, although it got a later start, there's, depending on who you talk to, 2,000 to 4,000 the medical cone beam CT systems installed, and they're growing exponentially. And as Dr. Siegel mentioned, really the diagnostic fidelity, it's really a game changer. The fact that, for example, you can get the additional details on the procedure right there in the office where the patient is. That's why point of care imaging is so important.
Gary, do you happen to know what percentage of dental facilities, or maybe Christine, are actually accredited at this point? Because I know when I talk with my own dentist and talk with family and friends, that in general, there is not that knowledge or understanding of accreditation or the importance of it. Do you know about what percentage?
Yeah, there's about out of the, let's say, 50,000 dental offices, there's probably 500 to 600 units that are accredited. So it's just a very small percentage. And, you know, I think just to restate, you know, you need to be accredited to get reimbursed by CMS. It's a mandate. Sometimes accreditation is voluntary, but in this case, based on the Medicare Improved Patient Protection Act of 2008, if you want to get reimbursed for a Medicare beneficiary, you're going to have an accreditation from an organization like RadSite. RadSite is the first accreditation body to have a standalone accreditation program for medical cone beam CT. There is another accreditation organization that also has a dental cone beam CT accreditation program that's been around a couple of years. But also it should be expected that private payers, which they already do today, are going to require the same accreditation. And, it's important to note that RadSite takes an educational approach to accreditation. So it's really about, and as you'll hear with the other presenters, it's a pathways, a journey about really you embracing the new technology and capabilities that Dr. Siegel describes. In my career, going back to 1996, I like to say that, I've accredited or gone through over 5,000 different organizations have applied. And every organization has at least made some change along the way. And that's where the educational feedback loops come so important. So RadSite does not try to make this artificially difficult. We really kind of have a process that is, it's very structured. There's several different opportunities to get feedback through the desktop review part. And then as you'll hear in a minute about the part where the radiologist reviews the images and we look at the physics. So it's exciting that every organization that goes through is going to make some improvement. And we're also going to listen because we're learning along the way. I mean, Christine Taxin, for example, has been a mentor to us in terms of understanding the nuances in the dental field. And we're working with companies like DentalRay to really make sure that the interpretations are appropriate. The other thing that's important to note is that you can use accreditation as a proxy really to kind of reinforce the clinical workflows and pathways within your organization. And we'll talk a little bit about some of the standards just to highlight what we're doing there. And for example, RadSite is in a position where we're also a research-based organization. So we're trying to see kind of what the kind of leading edges on certain issues. For example, on the traditional advanced diagnostic imaging side, we've kind of taken the leadership on the implementation of remote technologists, which is not occurring in CBCT. We're working with, for example, RSNA on quantitative image biomarkers. So we really are trying to not only kind of embrace these emerging workflows under CBCT, but also to basically make sure we're anticipating what's coming down the pike. The other thing too is I like to tell a humorous story. Back in the late 1990s, when I was running my first accreditation organization, we had grown tenfold during my tenure there as the president CEO. And about 2 or 3 years into it, we were growing rapidly. And I realized that we needed to kind of walk our own walk. So I actually had our accreditation organization apply for our core accreditation standards. And, the accreditation committee didn't know it was us. And when I first, suggested this to staff, you think I, declared World War III, they were very upset. It took us 6 months to actually prepare to catch up to have the written policy and procedures because we had been growing so rapidly. But we actually did get accredited after, about 6 months, and we didn't get a perfect score. But I was really surprised about how really going through the process prepared us for the rapid growth that we experienced over the rest of my tenure there. And just really kind of the benefit, whether you're talking about risk management or just kind of workflow. So I think accreditation really can provide a lot of value to an organization beyond the specifics of trying to, optimize getting the reimbursement.
I would like to just say one thing here as regards to being accredited. I think that the dental world has not understood the movement as much as we have within the medical world. But having the ability where even at the dental code committee meeting, CMS is at the table. And the reason for that is because electronic health records are going to have to be part of the dental world sooner rather than later. And the reason why they made so many codes, for example, in the CBCT world, even though 90% of the dental plans don't cover it, is so they could track what are we billing and what for. And that's number one, that we don't really see that as the reason why they're doing some of the things they're doing, but those are the reasons. And the second thing is, if we are going to purchase medical equipment to utilize as diagnostic tools, then we have to understand the legalities behind it, because we've stepped into another world, whether we're doing sleep apnea, whether we're doing implants with bone grafting, we're doing more complicated cases and we're doing more medical cases. So having the machine accredited is not just on CMS. There are more and more insurances that are going under that umbrella because they understand the idea of maintaining the CBCT scan as important, the reading of the CBCT scan as very important, and the fact that if there is something else, our job is not to fix it, our job is to refer. And that is something that we absolutely have to have and be part of, because if we're going to help save lives because of some of the images we see, or doing sleep apnea, or helping patients with temporal mandibular, we're actually helping people. And we have to continue on that road. We don't have to learn everything because we have a team that could help each other. And I just want the dental practices out there to understand that the big DSOs that are taking over a lot of what we do understand a lot of this. And the single practitioners look at it as, I don't have that kind of money. Well, it's up to us to make sure that you understand you can't afford to not do these things if you purchase a CBCT scan. That's my humble opinion from seeing things change so much in dentistry. But yet the young people in the universities today are working on CBCT scans. They're learning how to utilize them and how a radiologist is reading them. And the schools understand that you have to have accreditation and the ability to have the machine working the right way all the time. So the young kids coming out are going to know that. And sometimes we have to listen to the young people of today to hear what they are learning and why it's important for us when they come into our practices. So I just wanted to add that in there.
You know, it's so interesting because what you're describing and what Dr. Siegel's describing, which we'll be talking about more about today, is the emergence of clinical practice guidelines and how you do this right. So really the dental field, there's an acknowledgement and we'll hear more when you speak about really, because you're billing under medical, it is a medical procedure. And what happens is the nice thing about accreditation is that it's your partner in terms of, so we're working with emerging clinical practice guidelines that, as you said, Dr. Siegel, that at some point covering CT is really going to be the default diagnostic imaging for certain types of situations, both in dental and medical. And then we work on the other side with the payers and their guidelines to help make sure that that practice is considered medically necessary and gets reimbursed under insurance. So we provide kind of that credentialing mechanism for payers. In addition to working with the applicants and the accredited companies to improve their practices, we partner up with the payers to really make sure they understand and pay for these essential services. So, you know, just as we kind of wrap up the quick overview, and I'm going to ask Dr. Siegel just to highlight a couple of our standards, but these standards were more or less structured, and you can download them, by the way, on a complimentary basis if you just go to RadSite's website, which is radsitequality.com, but it basically has basic overview of the imaging systems, the locations, which CMS calls imaging suppliers, the professional requirements related to the clinical director, the interpreting provider, the technologist, the image safety officer, and the physicist that's helping do the assessment. And then it gets down to the details of some of the policy and procedures that you need, some of the quality assurance activities, and then a technical component related to looking at when you apply for each imaging system, you have to upload typically 3 images for us to look at. and then a physics report, which we'll talk about in a minute. But we're pleased to report that RadSite has established, again, a kind of a best-in-class experience. We charge a very reasonable accreditation fee. It's a one fee. We don't charge any, secondary or hidden fees. Because Dr. Siegel and I actually can't make the accreditation decisions, we're accountable to the accreditation committee that makes the decisions. All applications are de-identified. There's a very structured process in how that happens. We have, as you'll see in a minute in the next slide, kind of a accreditation portal, which helps you manage the accreditation experience in a very seamless way. When you apply, you're assigned a customer support manager who's there to answer any questions. And again, throughout the process, we're going to give you a second, third chance, kind of try to get it right before we actually send it to the accreditation for approval. Accreditation are good for 3 years based on CMS requirements and the payers. And it's really been a wonderful experience to really leverage this accreditation program, kind of take it based on the CMS requirements, but really kind of put our own personal touch on it to really, we hope, make it a good experience. This is the accreditation portal. So leveraging, my quarter century of doing this, I like to remind myself sometimes when I first started the accreditation field, when you got an applicant, you get a bunch of boxes delivered, a bunch of paper. At some point about 20 years ago, we started moving to electronic, but really it's so important to have a kind of superior experience, because this is where an applicant is going to learn a lot through the portal. They also can just upload all the documents. We've really tried to optimize things. Everything is HIPAA compliant. If you're a large organization, we can actually customize and kind of create an enterprise-wide portal for your organization. But it's somewhat automated if you're just a single site in terms of how you kind of handle this. So Dr. Siegel, if you mind, I'm just going to highlight a couple standards, but obviously,
Gary?
Yeah, go ahead.
Sorry to cut you off. I just wanted to go back to your portal, and if you don't mind, I want to say something. I've had a few of our dental practices that have utilized this portal, and it's a really impressive experience. And let me tell you why. There's other, obviously, accreditation programs, and I've seen them. The way that this portal is organized makes the accreditation process easy and seamless. And you can tell RadSite is really invested in this. And this means something to a practice, right? Because when I think about the practices that I've worked with and the practices that are probably on this call, you are all extremely busy. You've got a lot going on. You run a very full schedule. And when you're moving towards accreditation, it's important to have something that's well organized, and you know exactly what that next step is. So I just wanted to call that out. I don't know if you cover that at all, Gary, but I think that's an important thing for them to know from a user experience standpoint.
Well, thank you. We take great pride, and we have full-time developer that's always tweaking this, and we're very proud of what we've been able to come up with. And I do think it's accreditation is, as you point out, Caleb, practices are very busy. If we can, at the end of the day, what we want to do is have you focus back with your patients, right? That's the main goal, and to basically implement as much evidence-based pathways as you can. So our small part is part of the portal and part of the accreditation experience really tries to get you from point A to point B as quickly as possible. But by the way, as a quick aside, we do offer a lot of ongoing educational opportunities like this webinar today. In fact, we've done a lot on cone beam CT, and we publish white papers and things like that. So we're always trying to make sure we're offering more than just the accreditation itself. So, so Dr. Siegel, do you want to talk? So I have just a couple of the key, kind of standards as you're aware, but do you want to talk a little bit about kind of our interpreting provider requirements? And obviously we're going to talk a little bit more about that with DentalRay as well in the next section.
Sure, we can talk specifically about the requirements for number of studies. We break it down into two different areas. And so I'm looking at table 4B. which is specifically for cone beam CT providers. And as you can see here, it's broken down according to two different categories. One is baseline experience requirements. So that would be sort of like what Christine was talking about for new practitioners to cone beam CT. And, there's a couple challenges with making the transition. One challenge is that as you make the transition from conventional X-ray to CT, that is sort of a whole new world. And there's, specific education and requirements. CT is very different than just conventional X-ray. The anatomy is different, and the best way to interpret these studies is different. Different planes for viewing the studies are different also. The other thing that's interesting is that there are specific things about cone beam CT that are different from conventional CT. So, even radiologists who are really trained and familiar with conventional CT of the mouth also essentially see something different with cone beam CT. And so the bone looks different, soft tissues look different. So it's really important whether or not you're new to CT or whether or not you're new to cone beam CT to have that baseline experience prior to actually creating those reports that Christine was talking about. And so our baseline experience requirements are different than the requirements for somebody that already is practicing and has been practicing and wants to continue to essentially maintain their skill and expertise. And so as far as numbers of studies, we ask that we believe that 100 supervised cases where essentially there is a physician that is overreading the studies. There are a number of ways to be able to work with somebody. Many practices have a library of cases, or many practices may allow one to look at cases retrospectively. And so one can look at new cases with another person who's experienced in cone beam, or one can have somebody take new cases that you're doing at your practice and actually go over those with you and supervise those. So essentially 100 supervised cases totally, with someone physically present for 35% of them. And the first 50 cases need to be overread by an interpreting physician or dentist for each of the modalities. As far as number of hours for dental practice, it's essentially 150 CMEs over that period of 3 years. And of course, board eligibility is required. And then as far as continuing experience, we want to make sure that whoever is continuing to interpret these studies have a reasonable number of studies that they're doing. So over a 3-year period, 250 studies, which would be somewhere in the neighborhood of about say 80 per year or so. So I think that's probably pretty realistic. And I think the vast majority of those doing cone beam CT will, find that fairly easy to be able to meet. And then also, specific CE hours, so continuing education, such as, courses like this, and to have 90 total hours over those 3 years. So that would be 30 hours per year. And also 36 of those hours, for more specific to things related to cone beam, including radiation safety and other practices as well. So those are the overall requirements that, again, are broken down into baseline experience requirements to get started, and then continuing experience, where we're looking at numbers of studies read over 3 years, and also number of continuing education hours.
Could I ask a question, Dr. Eliot, to
Sure.
clarify that just a little bit?
Absolutely.
When an office is already using a CBCT scan, and now they want to be credentialed,
Yeah,
They have films, scans already.
yes,
So can they use those scans to start this process?
absolutely, yes.
But what happens if they have not been read by a radiologist with an official report from a
Right.
radiologist?
Yeah, so
Can you
as
go
you
into
were
that a little
mentioning,
bit?
yeah, so as you were mentioning, it's not just a radiologist, it's another practitioner, a dental practitioner that has been interpreting these studies. So
Right.
for each one of the studies that they would have already done, the question is there a report that has been generated for those studies? If there has not been a report that was generated, they can go ahead and look at those studies retrospectively and then find somebody who would either be a dental practitioner who does have this level of experience themselves, or a radiologist, somebody with the expertise and experience. And so that's who would need to essentially overread those first 50 cases. And so it doesn't have to be prospective new cases. They can take cases that have already been done. It's also possible to be doing those overreads in someone else's practice. And so being able to go to another practice where they've been doing these and creating reports, looking at the studies, even writing down what the impression would be of the dentist who is new to the practice, and then comparing that with the official report and going over those, that would work as well. And I think that would be easier. Plus, there's the possibility of some educational organizations that could have a library of cases that would be typical cases, and then to be able to go over those cases. So we believe, and I know our dental experts, believe that having those 50 first cases overread by an interpreting physician, and then an additional 50 for a total of 100 really is probably the minimum that would be required. And I would think that most dentists who are making the transition would feel comfortable before they were issuing reports with having that level of supervision and that level of education. So I'm happy, to take questions as we move forward, and just, either on this webinar or afterwards on some of the specific questions. But really, overall, what we want is 100 cases for someone who hasn't done it before, but there's a lot of flexibility. And so thanks for underscoring that, Christine, as far as the where to find those cases. And I think most practitioners will find that they can hit the ground running as they have a new system by spending time in advance, finding somebody to help out as far as the supervising dental expert, and then also finding cases either that they've done at their practice or at someone else's practice.
Well, one thing just to put in there, Dr. Eliot, in my book, I have a template. So they can follow that template so they can make sure they can document every single area that is on that CBCT scan. So they are writing the report that's needed. And then maybe if they don't know what to write, for example, in the cervical, because that's not something they do normally, then that's when they can contact a doctor that is doing it, a radiologist that's doing it, so that they become more familiar with the areas they don't know how to read.
Yeah, and Christine, your book is really very helpful. Radiologists in general are finding that the templates are extremely important for radiology reading in general. Practically 100% of radiologists nowadays will dictate into a templated report, which serves as a reminder of all the different areas that you want to comment on, and that's faster. A lot of people are doing speech recognition using systems like Dragon, and others using templates specifically. But I think the templates that you talk about in your book are great. And in general, CMS and other payors are used to having reports that are issued in a templated format. And I think that's something that they would very much look at. And so I know you're really happy to take, feedback, and I'd be really happy to get feedback from dental practitioners who have ideas about improving the templates or customizing templates specifically. But I think that template reporting is really critical. And I think that's part of the learning process with that supervision by other practitioners who have experience interpreting imaging studies and generating those reports, which I know most dentists at this point really don't generate radiology type of reports. But I think using your template, they'll find that it's very straightforward and easy to do that. I think you get the knack of it pretty quickly and find that a lot of your reports are relatively repetitive. In other words, there's a lot of elements from patient to patient that are very common, which is why a template can be so incredibly useful.
Well, thank you. And everybody's going to get a book today.
Great.
So another big aspect of kind of the workflow is who's positioning the patient and who's pushing the button. That's obviously called the technologist. And obviously, there's often a difference between a certified technologist in a outpatient imaging center versus, let's say, a dental hygienist in an office. So similar to what Dr. Siegel described in terms of the baseline and ongoing experience requirements, we carefully work with CMS to come up with a pathway. So, for example, a dental hygienist could get basically authorized to run the cone beam CT imaging system as they are. And that not only includes some experience in terms of operating the equipment, but also making sure they're getting basic coursework completed on how a CT operates, ionizing radiation, and making sure they have some sort of baseline licensure or certification pursuant to their practice in dentistry. So we're excited that we've been able to kind of document this workflow, which is obviously embedded in our standards. Obviously, if for some reason they have the traditional, like let's say AART certification, then it's more straightforward. But we do have a way, as I think in most dental practices, to basically work with the staff like dental hygienists or technicians to actually be able to operate the cone beam CT imaging system. Is there anything else you want to add regarding the technologist?
No, just to summarize, 25 examinations per technologist need to be supervised by a medical or clinical director in your practice or another practice. The imaging technologists need to have 20 continuing education credits for dental imaging, and it's really important that there's baseline requirements for techs and continuing requirements for techs. So techs need to continue doing approximately or continue doing 25 studies per year, or a total of 75 for a 3-month accreditation cycle, and need to essentially have CE hours over that 3 years, 30 continuing education hours, particularly with a focus on patient safety and radiology education. In general, it's the manufacturers or the vendors who will educate the technologist or the person designated as the technologist when that initial training occurs, and then manufacturers and vendors offer ongoing additional training too. And so those are really the basic requirements for the technologists themselves. And as Garry said, the requirement is not for a radiology technologist per se, but the requirements are fairly flexible and adaptable to individual practices to designate the technologist under the assumption that the technologist has a certain amount of experience, has done a certain number of studies, and continues to get education with a focus on radiation safety and a focus on best practices for cone beam CT.
Thank you, Dr. Siegel. So a big part of the review process is for the submission of 3 images, a fourth if you have pediatric cases you regularly see. You want to talk a little bit about that process and what RadSite requires?
Well, yeah, I mean, without going into a huge amount of detail, there are technical requirements with regard to physics requirements. It's really important from a physics perspective, for example, that there be an annual physics evaluation of the equipment and report that's associated with it. It's really important also to have the physicist evaluate certain characteristics of the image, such as spatial resolution, which refers to the amount of detail in the images, and also a number of parameters that are specific to cone beam CT quality that may be different from CT quality. Essentially, what we really want to do is make sure the images are clear from the perspective of being able to see fine detail and also being able to make the distinction among different types of tissue values. And so the contrast of the images is really important too. And those are all things that are evaluated according to the manufacturer's specifications, and making sure that one meets the phantom, which is the object that is used by the vendors to determine the quality of the scanning. And then we also have standards that address looking at parameters that would cut across multiple different cone beam CT scanners. So one would be able to look at how to measure dose across multiple scanners and how to look at quality across multiple scanners. But at this point, the basic question is meeting the manufacturer's own requirements for the testing that the manufacturer has at the frequency that is required by the manufacturer. Any other comments about that, Gary?
No, I think that, and obviously reach out to RadSite. This is a new activity that most cone beam CT imaging providers have not engaged in. So we'll work with you offline to explain how to basically get the physics testing arranged and follow up. And to your point, Dr. Siegel, it's really because there's not universal uniform phantoms yet in the cone beam CT space. Using the manufacturer phantoms, which you have on site, will be sufficient to meet our standards.
I think one thing that's really important, Gary, is that the practitioners of cone beam CT, dentists, technologists, et cetera, that they feel comfortable that what they're doing with their machine is effective, high quality, and safe. And I think it's really important to be able to, via accreditation, assure patients that that's the case also. I know CT in general in radiology has received a tremendous amount of scrutiny about radiation safety and protection and amount of radiation. And as we go to lower and lower doses in cone beam CT, I think it's really important to make sure that we're maintaining quality while minimizing the dose. And I think educating patients about the importance of accreditation as a way of reassuring the practitioners at the practices and also the patients is really critical nowadays, particularly for patients who have concerns about safety related to CT. I mean, I believe that CT, when done responsibly with cone beam CT, really is as safe or likely safer than conventional X-rays that are used in dental practices, often with lower radiation doses and with much greater information and detail associated with it. But the best way for any individual practice to be able to test that they are doing high quality safely is to go through that accreditation process and to educate patients about how important that is. And as you pointed out, in addition to just doing this so that one can do billing for reimbursement from CMS and the payers, I think that reassurance as far as quality of the images and safety of the doses is really important.
Right. And how about the second half of the technical component regarding the image submissions per imaging system? Can you just say a few words about that?
Sure. So one thing that's really unique and really important from the perspective of RadSite is making sure that we're not just looking at things from the physics perspective, but we're looking for things from the clinical perspective. So, the question is, are the images that are obtained something that a dentist with expertise in cone beam CT imaging would feel comfortable doing an interpretation on? Would a peer who has expertise in CT interpretation of these areas, feel as though the examination that was performed properly? Would that expert, believe that the study was of a sufficient quality and that the dose used was the reasonable dose for the patient, given the indication for the study, and that the report is a reasonable quality report? And so, unlike any other organizations, it's important not that we only look at the physics parameters, which we probably do more than any other accreditation organization, but also from a clinical perspective, is the report itself essentially addressing what are the important points? And the emphasis is not so much on pass fail as far as the evaluation, but how can we create education? If there's a difference in opinion, even about the images, that information from the expert will be conveyed back again. If there are ways to improve the quality of the image or slice thickness of the image or other parameters to create a better quality image, those recommendations are passed along also. So really there's the physics perspective, but there's also the clinical perspective, which I think feeds into what we were talking about continuing education and continuing feedback. And so those are all really important. So that clinical review is also an integral part of the accreditation process.
Yeah. And it's important to know we have trained radiology reviewers and physicist reviewers, and if there's a deficiency, we're going to communicate that back to the applicant and let them resubmit until they get it right. So this is part of the kind of two-way communication to really, if there's, for example, a deficiency in terms of the read and the report, there's going to be very specific information why that's deficient, and then there's going to be another chance for the applicant to resubmit that.
And really the object of the game for us is to essentially help out in any way we can to elevate the quality and safety of the studies and to provide that feedback. And the aim of the review is not essentially just to make a accreditation plus or minus decision, but really to try and get everybody up to certain levels of standard that I know we would all want to achieve with regard to patient safety and image quality. And we work really hard to evaluate and then provide that feedback for the studies in your practices.
So as we wrap up, just in summary, it's much more than just going through traditional accreditation program. I think it really is transformative the way that we put this together. You do get a accreditation certificate with describing your accreditation for each location, for each imaging system. You're listed on our online directory. We actually give your information to CMS and several other payers, so they'll reimburse you automatically as part of the process. But again, the accreditation committee will ultimately take the executive summary, it's been de-identified, and either once a month during the face-to-face meeting or via email in between, we'll go ahead and process the application. If for some reason there's an adverse determination that you're not happy with, we do have a structured appeals process. When we've done kind of satisfaction surveys, I think people really give us kind of high marks in terms of how we run this process. So it's Dr. Siegel and I have really enjoyed. We're constantly trying to upgrade the standards, fine tune them. We're trying to stay abreast of things, and as the industry catches up, I think good things are going to happen. At the end of the day, again, it's about the patient, about promoting evidence-based pathways. It's about making sure I'm getting the right image at the right time. And for the dental office, as Dr. Siegel described, it's going to be cone beam CT more often than not, and then these other areas too. If I'm seeing an ENT, why do I get referred out, at a later date to see a CT with more ionizing radiation when a cone beam CT at the office while I'm there can make a difference? If I'm getting knee replacement surgery, why don't I get the image from a cone beam CT unit where I can put weight on that knee in the office versus being referred out later? It's just such a time saver. And then finally, just a reminder that we have 3 or 4, for example, webinars that are complimentary. You can see on cone beam CT itself, looking at different aspects of our standards and what's going on in the industry. And we encourage you to reach out to us if you have any questions. Again, you can download the standards for free on a complimentary basis. Dr. Siegel and I look forward to participating in the rest of the webinar today. So Caleb, we'll turn it back over to you.
Thank you, Gary and Dr. Siegel. Really appreciate it. A couple questions that I wanted to pose to you that we have here. The first one is, in regards to medical reimbursement. Question is, does accreditation open the door for greater medical reimbursement? And Christine, obviously, you can jump in and answer that too.
Yeah, I mean, absolutely. So CMS, obviously was the first to recognize this. That's kind of the tradition of what we call the MIPA accreditation program. So cone beam CT is treated for reimbursement similar to CT under CMS. And then we are working with the private payers to make sure they're embracing this. In our journey, when we first got recognized by CMS in 2013, anytime we're aware of a payer that's not reimbursing, I'm actually the former general counsel, what's now AHIP. So I have very strong relationships with the payer community. And so we will work with any, as more and more payers kind of understand. I mean, the interesting thing is a lot of payers still are not familiar with what cone beam CT is. It's actually very surprising. I've talked to some very sophisticated payers over the past couple of years. And so we're playing that role of educating. We do have also the kind of work groups that are forming to actually kind of reinforce the payer guidelines. We're taking kind of a leadership role in that. So yeah, absolutely. I mean, this is, in addition to all the aspects of quality and performance, it does not make sense for you to either absorb the cost or have to bill your patient. You want to take advantage of medical insurance, just like you do for other types of imaging modalities.
But Gary, to my understanding, in order to get reimbursed as a medical CT scan for a medical oral cavity procedure, it's mandated to be credentialed in order to get CMS reimbursement or from a subset of payers.
That's correct.
And that I just want to add to that, yes, because when you look at anything about accreditation, CMS is the big kahuna, so to speak. And dentists are still afraid of CMS. And we shouldn't be, because having them accredit you the way sleep apnea worked. So I'll give them examples. When you become a sleep apnea provider, the one thing every doctor should want is that credentialing from CMS. Not because you have to be a network, but because when they give you that accreditation, other insurances will consider you payable. You've been looked at, you have done the right thing, you're working with the right appliances, and you're referring these patients back to the sleep apnea providers and not trying to diagnose on your own. So the same thing with the CBCT scan. Why are we working together? Because CMS, you may be getting paid right now from plans, but that doesn't mean that they're not eventually going to come and say, you're not accredited, or you don't have the ability to do some of these things. But the biggest issue is going to be when they can't prove that they read that scan. Because I'm in offices, I'm teaching offices how to bill. And the first thing I'll say is, do you know how to write up the scan when you are taking it? And there's a lot of misconceptions and myths out there about that. And the biggest myth is, well, I don't have to write the whole thing because I don't want to talk about that part. Well, that's a myth. And the second myth is, what if I see something I don't like? Well, refer them out, just like you would if you were seeing an endo that you felt you could not do. Our responsibility as a general practitioner is to know our limitations and to be able to refer out. So no matter what you write, the doctors, 90% of the dentists today do not even document x-rays. They order them maybe, because a lot of times the team is taking x-rays without the order of the doctor, because they look at what insurance is covering. So if insurance says you could take a full amount, that's what we're doing. And that's not the way you take x-rays. They have to be ordered, and for a reason. And so we've gotten away without, I don't know, for years and years, without the actual order documented. And then what do we see in those x-rays? So if you think that this is a big deal, that you have purchased this CBCT scan, but you still don't even order and write what you see in a regular x-ray, then this is where you need the help to actually become compliant and have the help that we could all help you with, so that there is compliance throughout your practice, which is the issue I look at, because I see what they're doing and I know what they're doing and I know that it's incorrect. And eventually it catches up to all of us. It's like driving down the wrong side of the road. Today you don't get caught, but tomorrow there will be somebody that catches you. So it's just the same thing. And I've been having experts like you and DentalRay and, you know, the input. And why do you think there are programs for assistants that could be taken to become certified CBCT scan equipment people? Because they have never had that. But there are states that mandate, like New Jersey, that an assistant has to be certified to take a regular x-ray. So that's, you know, there are state laws that we're still obligated to follow. And we have to know what our state laws are also. So there's a lot entailed in, you know, not just buying a toy, but knowing how to use the toy. So that's my input.
That's great, Christine. And I'll be careful not to drive on the wrong side of the road.
Yeah, please.
Yeah.
Could you put me back on?
Yeah, you mean your video?
Yeah, I don't know why that went off.
I just enabled controls, so give it
Okay.
another try at the bottom. Okay, great. Thank you so much for that portion. So before we move on to Dr. Brown and him walking through kind of interpretation and the things that he has said, I wanted to ask the audience here, our attendees, a couple of questions. And I'm just curious. So you'll see in Zoom at the bottom, you can raise your hand, right? And I'm going to ask you a couple of questions, just curious. How many of you or your offices have CBCTs? I'm going to give you a little bit. Yeah, there we go. So it looks like it might be interesting for everybody to hear here. About 30% that are on this have CBCTs.
Mhm.
So, which is interesting because that's about what the industry has. About 1/3 of the industry right now has CBCTs. So, okay, let me ask you this question. I'm going to lower all your hands. Okay, here's the next question. How many of you are going to get a CBCT within the year?
Two.
Okay, just a few of you. Okay. All right. And then let me ask you this last question. I'm gonna ask a few more questions as we kind of go, because I think it's interesting for us to know as presenters and how to talk to you. How many of you are currently accredited?
None.
Okay, great. Okay, well, thanks. Well, with that, Dr. Brown, we'll pass the time over to you.
Excellent. Thank you, Caleb. Can you hear me, Caleb? Can you just give a thumbs up?
Big thumbs up.
Awesome. All right. I am going to just try to share my images here. So we can see some pictures. 1 second, Caleb. Apologies, everybody. I'm going to just jump off real quick so they can let me share my screen. 1 second, please.
Not a problem. In fact, while he's doing that, I'm just going to walk through a couple of slides. Can you all see my screen right now?
Mhm.
Christine?
Yes, we can.
Okay.
Yes.
Okay. So while Jacob's doing that, I mentioned earlier that I'm the CEO of DentalRay. Jacob is our chief medical officer and also a radiologist. And essentially what DentalRay does is we automate radiology and medical billing for the dental industry. When I say medical billing, obviously we've got partners like Christine that we work with in regards to that. But this is something that we feel so strongly about. We obviously created this company. When we work with a practice, we have what we call a sync app that we install on a computer, on your radiology computer. And what this does is it automatically pulls over your images. So you don't have to do anything. I know there are different services, companies out there that there's a manual process that you have to go through. So every image you want to send out, or if you're sending locally to a radiologist or an OMR or OMS that you're sending to get kind of a second opinion, there's that manual process of downloading it and then uploading it. And as simple as that sounds, sometimes there's 10 steps in between. But our sync app essentially pulls over all images, and we read all images and send back an interpretation and a report. And we'll show you an example of that a little bit later today. But just to kind of give you a visual of how easy our process is since that sync app, that software is on your computer, you essentially take the 3D image and that's it. The rest of what we do is our software automatically pulls it over, and then we give a radiology interpretation report. You can see that in step 3, small example reports, and we'll show that to you in just a second later in our section. And then based upon that, if there's any critical findings, we'll obviously circle with a consultation on that. And then you get a medical reimbursement. So, I mean, it's as simple as that. We'll probably go into a little bit more detail there. But wanted to introduce you a little bit to that. Sorry, go ahead.
Sorry, I was just letting you know that I think I'm queued up now. If you want to just let me share my video again one more time, please.
Yep, absolutely.
It's just indicating that it can't start my actual video screen. Caleb, I don't know if you can allow me to.
Okay, just a minute. I might have to remake you a presenter. That's probably the case. There we go. Give that a try. By the way, we can see your screen now, Jacob. Is it the beyond the oral cavity slide?
Perfect. Thanks for your patience. You'd think after a couple of years of Zooming that I would have become better at this. But wonderful to be here with you all today. And this is a very exciting time in radiology. It's always an exciting time in radiology for me, but especially as Eliot and Dr. Siegel and Garry introduced, especially as we start to advance the quality and efficacy of point of care imaging. As a little personal story to just kind of reinforce what Garry and Eliot were discussing. I'm the black sheep in my family because I went into medical school and I became a radiologist. A lot of the other folks in my family are dentists and dental specialists, and my dad and my brother are orthodontists. And then I have several cousins who are general dentists. And it's been super interesting to talk to them as we've gotten into cone beam CT imaging. And it just illustrates the heterogeneity out there in dental practices. So I have my brother, who's an orthodontist. He has a CBCT scanner, but he'll only take a 5 centimeter field of view because he says, hey, I don't really know what I'm looking at beyond 5 centimeters. It's basically like a bite wing level of field of view. And then I have another friend who's practicing in another state who just takes an 11 centimeter field of view on everybody, regardless of what he's looking for, because that's the way that the CBCT manufacturer set up their machine, and that's the way the staff members know how to operate it. And then I have another cousin who wants to buy a CBCT scanner, but he won't because he's worried about liability issues.
Mhm.
Because you know, his wife, who's also a general dentist, there was an issue with an adverse outcome in a patient who had received a CBCT scan, but it was never really reviewed, and there was some overlooked pathology there. So this is an area that's near and dear to my heart, and I'm a radiologist, as was introduced, like Dr. Siegel. And if you, just in case some of the participants aren't familiar with a medical radiologist, so that's the training is medical school, and then 5 years of residency, and then usually at least 1 or more years of fellowship subspecialty training. So my my subspecialty training is in neuroradiology and head and neck imaging, and Did that slide advance, Caleb? I just want to make sure that you guys saw that advance. Are you on a slide where you can see some images?
Yeah, it advanced, and you might want to push the play button up at the top, Jacob. That might give you a better real estate.
Oh, that's very helpful. Thank you. This is great. I'm gonna finally know what I'm doing with Zoom at the end of this. Yeah, so I mean, it's been extremely impressive to see what, as Garry and Eliot pointed out, to see the way and the advances in cone beam CT. The quality that providers are getting at the point of care is really pretty astounding to me. And we all know that this field is moving quickly. The field of view that you're obtaining whenever someone does press the button is increasing generally as scanners kind of become more sophisticated. And the types of pathology that are within the field of view are becoming more complex. And that all leads to this conclusion that, you know, it's really critical. I mean, I'm not trying to, my brother and my cousins are certainly experts in the oral cavity, and that's absolutely where they're experts and where their training is. My desire is to see if I can come and add in an additional review, a comprehensive review of every anatomic subsite that's visualized on the scan, because there's often incidental findings or things that sometimes there are critical findings that can be very subtle and overlooked. So what I want to do is just, hopefully this will be kind of a little bit fun and interactive. I just have some show and tell here. And we're just going to go through some images, and some of this will be kind of an eye test to see if you can see anything abnormal. But again, as Garry and Eliot pointed out, CBCT has a tremendous potential to improve health and detect disease at the point of care. So another little story is that you know, one of our dental colleagues had a patient, and he had obtained a Panorex, and he saw what he described as, quote, something in the maxillary sinus, but didn't know what it was. He had a cone beam CT scanner, but you know, there were concerns, as Garry and Eliot brought up, of, you know, do I absorb this cost in my practice? Do I need to? How do I talk the patient through the radiation dose? Is this going to you know, result in me seeing things that I don't really want to see, or I won't know what to do with? So from the initial X-ray, because there was this kind of unknown thing in the sinus, the patient was referred to a local ENT and had the clinical visit. And then the ENT referred the patient to the only traditional CT scanner in the town, in this small town, which was in a hospital. And then a person like me, a medical radiologist, finally interpreted the sinus CT. The patient received a higher radiation dose because it was a traditional helical CT scanner. And they also, they were their copay, their out-of-pocket expense was more than it would have been. And then finally, the answer after getting all of that was that this was just a common mucus retention cyst that was in the maxillary sinus. So that, at this last bullet point here, where if we can potentially save our patients expense, worry, and hassle from going through that kind of odd feedback loop, I'm extremely excited about the service that we can provide, but it does have to do with making sure that we elevate the standard of care at the point of care. So a little bit of to just understand where we're going with CT, it kind of helps to know where we came from. You're looking at the world's first CT scanner, and the inventor, Sir Godfrey Hounsfield, this winsome gentleman right down here, received both a knighthood and a Nobel Prize for the invention of the CT scanner. And you can see that this is purportedly the world's first CT scan of a human brain. And does my let me see if I can get my cursor to point to show up here. Can you see a cursor moving around, Caleb?
No, I don't see a cursor moving around.
Got it. Okay.
But if you took it off play, if you hit escape, I think you would be able to do that.
Can you see a cursor now?
Yep, I can see a cursor now.
Excellent, thank you. Yeah, so this is the inventor of CT scans, and this image that was acquired here, the scan time, he proposed that, hey, we have X-ray, now we'll just take multiple projections as we move around the head, and then we'll use mathematical computation to figure out what the internal structure of the box or the head is. And one rotation took about 4 minutes. And then the computational power in the 70s required overnight post-processing of that imaging to just receive one slice of a CT scan. And today we still use to describe the relative scale of density in CT, the Hounsfield scale that you see down here in the bottom right. And that basically just assigns a number, a Hounsfield unit, to relative degrees of dark or lighter. So a lower number would be more black, and then a higher number would be more white. It just describes the density of what you're seeing. And that brings me to the concept of a tissue window. So when we're looking at cone beam CT, the typical output is, as Dr. Siegel referenced, very high spatial resolution, and it's particularly good for evaluating the bone. So on the left side of the screen, and again, hopefully you can see my cursor moving around here, but you can see the difference between cortical and trabecular bone here at the temporomandibular joint of the condylar fossa. And this is what's referred to as a bone window, where you're taking a very wide view. If you look at the spectrum, you're taking all the grays and the whites, and you're showing all the gradations. Using a soft tissue window, which is really essential whenever you're interpreting CT, narrows the difference to emphasize differences in tissue density. So here, if we look at the masticator space, so here you have the lateral pterygoid muscle. Caleb, can you just one more time confirm you can see my cursor moving here? So otherwise it might be hard.
No, we could see it.
It's moving.
Thank you, Christine, I appreciate it. Otherwise people will be like, what is he talking about? So I appreciate that. You can see, so fatty tissue, subcutaneous fat, darker here, black, behind the maxillary sinus. When we get to muscle, kind of an intermediate gray, there's a fat plane right here along the lateral pterygoid. And when we come over to the patient's left side, you can see that little tiny black strip of fat is gone over here. So that's a very subtle difference, but really critical to notice things like that. and to employ these different windows. So it's actually a manipulation of the images that's done by the radiologist when they're interpreting the image. And it allows you to pick up on subtle effacement. So a tissue plane that's been moved, displaced, or invaded by a structure. So in this case, this was a nerve sheath tumor, a schwannoma that was coming down from the mandibular branch of the trigeminal nerve. And you can see on standard, a kind of bone algorithm, bone window CBCT output. If you didn't manipulate the image at all, you can see that tissue plane is extremely difficult to appreciate. So that's just one of the things that, you know, an imaging expert would be doing when they're looking at images to evaluate the image comprehensively. Another thing, so I mean, it's a long time to be in training as a radiologist, and what you're really honing is your search pattern. So when you look at a complex anatomic site like the maxillofacial region, radiologists and people that are expert in interpreting CT scans break things down into anatomic spaces. And the reason to do that is because there are types of pathology that are very common to each particular space. So it's a way of methodically moving through the scan the same way every time and evaluating every part of the scan that's visualized. So as Eliot referenced, using a multiplanary format, so looking at the image in an axial plane like you see here, in the coronal plane where they're looking kind of face at you, and then a sagittal plane where you're kind of looking at the side of the patient is really critical. And then using those different tissue windows to emphasize different groups of tissue as you move through the scan. And what we're really looking for with cone beam CT is kind of a tip of the iceberg type of finding. And we're going to go through some of those that'll be, some of them I think will be pretty obvious. Some of them are pretty subtle, but often they can indicate signs of more severe pathology that might be otherwise occult. I think one of the points for me as I've been working with dental practices is that for your patients' safety, a consistent methodical review of the entire scan by an imaging expert. It doesn't have to be me, it doesn't have to be one of my colleagues, but somebody as Garry and Eliot pointed out, somebody who's a fully accredited practitioner who's demonstrated a sufficient level of expertise to review the entire scan is really, really critical. I really can't emphasize that enough. I mean, I guess an analogy might be, you know, in our hospital-based radiology care, when somebody goes to the emergency department and an imaging scan or a CT scan is ordered by the emergency physician, every time that a patient gets scanned, a radiologist is looking at the entire scan. So it never happens, or I hope it never happens, that an emergency physician would look at the scan and then decide whether they wanted a radiologist to review it, or you know, if it was a patient who had right lower quadrant pain and they ordered a CT scan of the abdomen and pelvis and they were worried about appendicitis, you know, they might be looking at the that area of the abdomen where the appendix is to see if it was inflamed, but you have lots of other organs that are in the abdomen and pelvis that also need to be evaluated because they're within the field of view, and they can potentially cause problems for the patient down the road. So a radiology or anybody who's an imaging expert reviewing the entire study is absolutely critical to keep patients safe, especially as cone beam CT scanner technology improves, the quality of the imaging improves, and the field of view increases. All right, so let's try. This is a little here's a little Where's Waldo. So take a minute. I'll just give everybody a minute here to kind of look at this CT scan. And I should note that as I do in my daily practice, I'm going to move pretty seamlessly through imaging modalities. So we'll have images from traditional CT, cone beam CT, MRI, PET CT, and ultrasound actually, that we'll be looking at. But yeah, take a look at the CT scan. So this is an axial plane. So the nose is kind of up towards the top of the screen. You can see the rami of the mandible, and then here you have the upper cervical spine.
And
This is
Jacob, can we make this interactive and have them raise their hands if it's abnormal? Is that okay?
I love it. Yeah. Can you? You've already seen how sophisticated I am with Zoom, Caleb. So maybe you can let me know. We'll give everybody a few seconds, 10 seconds or so, and
Yeah, let's give them 10 seconds. So if this is abnormal, we want you to raise your hand.
all right. I love it. So
Okay, so we've got 2, so not very many that think this is abnormal.
well, I bet we have a lot of I bet we have a lot of good test takers, people with great test taking strategy out there. And I'll give you a big hint. I'm not going to show anything that's I'm not going to show anything that's normal. So this is extremely difficult to see, though. So again, we're focusing and this would be the standard kind of output that your cone beam CT scanner is going to show you. It would be extremely difficult to see this prospectively. We're going to move to a soft tissue window, as I said. Are these blue arrows already here? Can you guys see that? That must be the fact that I'm not on it doesn't play the animation because I'm not in play mode, but I do want you to see my cursor. So we're going to leave it like this. So what we have is, over here on the bone window, you can see this little oval density. It's lateral to the ramus of the mandible. What we've done here is we've narrowed the window. Remember the Hounsfield units? We've kind of impacted them a little bit so that they're closer together. And now we can see more differentiation between muscle. This is the masseter, and then the fat, and then the gland. This is the parotid gland, which is slightly lower in density than the muscle because it has more water and fat content. And then this is a mass. This is a primary parotid neoplasm. And this is, as we referenced in the beginning, a critical space that's called the parotid space where pathology can occur. And absolutely, most of the time on a cone beam CT with the field of view that's being obtained, the larger field of views, the parotid space is within the field of view. It's absolutely critical to evaluate this every time. And I'll move on here. This is going to become much more obvious now. I think everybody can. We don't need to do a hand raise now, Caleb, because I think everybody can see this. What would you say? What color is this orange blob over here? So this is a PET CT, and that is a hybrid type of imaging technology that uses an injection of a radioisotope labeled sugar molecule. So it's called fluorodeoxyglucose. And it works on the principle that a tumor or malignancy is more metabolically active than normal tissue. So this tumor is taking up a lot of this radio tracer that was injected into the vein. And this is a very sensitive way to detect primary disease and evaluate for metastatic disease that spread to other parts of the body. So this is a pretty aggressive, unfortunately a bad actor. It's called adenoid cystic carcinoma. Here's an MRI. So we're looking at an axial plane. Again, this would be with the nose up towards the top of the screen. And then this is a coronal plane where the patient is facing towards you. So here, this is the same patient, and they have had a partial resection of this parotid lesion, but you can see what this is called enhancement, where it's taken up some of the dye that was in the vein. That's here at the skull base, and unfortunately, it goes up. If we follow this up, you can see these little blue arrows are pointing to you can imagine a kind of waterfall coming down right here. And unfortunately, this is the stylomastoid foramen, and where the the facial nerve exits the brain and comes down into the face and courses through the parotid. And this type of tumor is unfortunately very notorious for crawling along the nerve back into the brain. And this patient does have intracranial extension from perineural spread back along the facial nerve into the temporal bone. So really, really critical. I mean, obviously, a cone beam CT scan performed at the point of care, the purpose of it isn't to screen for adenoid cystic carcinoma. It hasn't been validated to screen for that type of test. But some of these things, when you scan enough patients, are going to be on the scan. And it's really critical to identify these fairly aggressive tumors as soon as you possibly can when it's a lower grade and they can be addressed with a better prognosis. Let's go on and do another hand raise here. All right, so look at this. We have an axial and a sagittal CT scan of the maxillofacial region. You can see part of the mandible. You can see the skull base and the upper cervical spine. We can see the airway.
So
Take
we're
a
looking,
minute.
so if we think this is abnormal, our hands are going up, right, Jacob?
I like it. Let's do that.
Okay. It looks
All
like
right.
we have a few more that have hands up than last time, so they might be using their test taking techniques here, Jacob.
I love it. I love it. This is great. Yeah. So this illustrates kind of the utility of multiplanar reformats, viewing things in different planes, 3 dimensions, to get a better spatial understanding of what's happening. And it also shows you kind of this tip of the iceberg principle, where what we're looking for is a subtle change in what's normally there, what should be there that's gone in this case. So in this case, we're looking at the oropharynx, obviously, and this is probably a view that's familiar to a lot of people that are doing CT, where you're looking at the airway and you're assessing for airway stenosis. You can see this abnormal rounded contour here at the base of tongue. And then the oropharynx, you can see, should look like this on the right side with that kind of smooth contour. And here it's irregular and nodular with this kind of exophytic contour pooching in and effacing the air. The air, remember, Hounsfield units is very low in density and looks black on CT. What we're going to show now is over here on the right side, a contrast enhanced CT where contrast has been given through a vein. And you can see this fairly sizable base of tongue squamous cell carcinoma, another bad actor. And over here, you know, a metastatic looking enlarged lymph node that's matted against the sternocleidomastoid. Again, this is unfortunately when disease is detected at a later stage like this, unfortunately has a propensity for metastasizing. And this patient with this base of tongue squamous cell carcinoma this is what's called a MIP, or a maximum intensity projection image from a PET CT showing numerous pulmonary metastases and abnormal lymph nodes in the mediastinum. Okay, let's try this one. I think we've got an A and a B on here. So let's go with, can we write in for A or B, Caleb?
We can't write in for A or B. Well, I guess we can.
Okay,
We can have you chat in. So chat in either A or B. You know, looks like chat might not be working right now for whatever reason. If you think it's A, just raise your hand. If you think it's B, don't raise your hand. Let's do that.
Okay, I think I saw some A's there. Okay, nice job. So again, this is a kind of what is where it shouldn't be, or what is missing from this image. And a radiologist and anybody looking at a CT scan, a symmetry, a symmetric appearance of the CT scan is definitely your friend. So we're going to look at the normal. This is normal from a cone beam CT, and then this is very abnormal. So we're at the level of the maxilla. You can see the hard palate and the maxillary sinuses, and you can see this is the nasopharynx. So this is a very characteristic and normal appearance. And this is, again, I just emphasize the quality of imaging that you guys are getting in your offices and with the accredited cone beam CT scanners is really amazing. This is highly detailed anatomy of the nasopharynx. So these little air-filled recesses, this is the lateral pharyngeal recess of the fossa of Rosenmuller, and then the torus tubarius, and then the eustachian tube, where you that kind of airplane feeling where your ear gets clogged up. This is where it opens the orifice into your nasopharynx. So a kind of opening your jaw can help to open this space and relieve that pressure, equalize the pressure between the middle ear and the outside atmosphere. So all radiologist or any imaging expert it's absolutely critical to look at all of these areas and make sure you're seeing these contours with no effacement of any of these contours. Over here in A, you can see that we're missing that little, here's the little clip on the left side, right? See this little black tiny dot right here? This is the pharyngeal recess of Rosenmuller. And then on the right side, you can see that that's obliterated. There's no little black cleft there. And this is a nasopharyngeal carcinoma. Again, another I would say, cone beam CT again has not been validated to use this as a screening study, but this is a disease with a fairly high incidence rate, and every dental practice is going to see enough patients that eventually there will be patients who have an early stage of this disease. And this is again is a PET CT to just highlight that that's a metabolically active, actively dividing, replicating tumor. Okay, this one I don't think we can do a raise of hand because we're not gonna write in, but this gets into the fact that with some of this cone beam CT, so again, we're way outside of the oral cavity with a lot of the cone beam CT imaging, and we can even choose to do that, as Garry and Eliot and Christine pointed out. We can choose to look at the entire paranasal sinuses and expand the field of view on purpose because we want to get more information and help the patient and save them the hassle and expense. When we expand the field of view and increase the quality of the imaging, we're going to see the intracranial structures. So you're looking at the level of the frontal sinuses. This is an air-filled frontal sinus of the forehead. Again, the nose is going to be up in this image if you're not as familiar with looking at CT images yet. And then all of this space in here is brain. Okay, so this is all fine looking. This is a bone window again, where we're going to emphasize the outer table, the inner table of the calvarium, and anything that has high density mineralization or calcification is going to look white. So if you're scanning through this image and you're looking in the area of the brain, you hopefully come to this area and you think, that doesn't look quite right. We're going to take a closer look at this. So then again, this is where that search pattern and moving to different windows to emphasize different tissues is going to be extremely useful. This is a brain tumor, a large brain tumor in a young patient. You can see that this type of tumor, which is called an oligodendroglioma, has a propensity to form calcifications like this. And then all of this darker area is mass and edema, where it's pushing the normal brain out of the way. Here's a hospital CT scan showing you the whole brain. You can see that the ventricle, which is a critical structure where the cerebrospinal fluid is getting circulated, is getting partially effaced, and there's midline shift, and this is a neurosurgical emergency. And this patient needs to have a surgery to remove that mass effect and the tumor. And then you can see this MRI shows you better the degree of the edema that's happening around this large. This is a temporal lobe mass. So you can see any cone beam CT that is up into the sinuses, getting into the orbits, is going to get a large portion of the anterior brain. And it's rare, but there are instances such as this where a larger tumor or a tumor with certain features like calcification can be detected by a CT done without contrast. So that would be another critical thing to look for. Okay, so we're on to another eye test here. So this is a small field of view in a sagittal plane or looking from the side. And you guys probably recognize this as the hard palate, soft palate, uvula, and then the clivus, the bottom of the skull, and then the top of the cervical spine. This is the atlantodental joint right here. And so the atlas is holding up the skull, it's resting on that bone. This is where the nasopharynx should be. So again, this is an absence of black air, a tip of the iceberg type of lesion that's absolutely something that can be seen by cone beam CT. And now I'll show you, moving again kind of seamlessly between radiology modalities. This would be a CT angiogram. So it's the same type of CT scan where an X-ray source and detector is spun around the patient's head, but this time you're going to inject contrast at a faster rate so that it's caught, the high density white contrast is caught in the arteries. And this is a highly vascular, all this white stuff is called enhancement, a highly vascular mass that's in the nasopharynx and it's eroding into the patient's sphenoid bone. And this is a benign tumor, but pretty fast growing and can be locally aggressive. It can get into the orbit, cause blindness, can get into the skull base, the sinuses, and tends to happen in younger patients at the ages of 10 to 30. So this is called a juvenile angiofibroma, and is another type of pathology that's definitely within the field of view on cone beam CT. And I'll just show you, this is another imaging modality called a catheter digital subtraction angiogram. So this just shows you, this is, I think, I just have to move this so I can play this. 1 second. All right, so this is a small catheter that's in the patient's, that came up through the groin, through a small nick in the artery, and is now positioned in the external carotid artery. And we're gonna watch, when we inject contrast through a syringe, we're gonna watch it go and flow into this mass, and it shows you how vascular this mass lesion is. So hopefully you guys can see a little video right now. Did that play?
Yeah, it did.
So you can see these vessels. This is the internal maxillary artery going to this mass. And you can see how many blood vessels are creating this kind of dark contrast that's embedding in that tissue of that mass. And that's really critical because, if this mass were damaged by an instrument or during a procedure, it can be really catastrophic epistaxis where there's just kind of uncontrollable bleeding. So the treatment for this is to usually come in with a catheter like this and let little microspheres or embolic material, little tiny beads basically, float down some of those little vessels until it stops some of that blood flow so that when surgery is performed, it isn't as risky. As we've referenced, and I think we've referenced, other uses of cone beam CT, including chiropractors would certainly be in this realm where we're focused a little bit more on the spine. But this is also an area that I'm showing you over here on the right side of the screen. This is from a cone beam CT that shows you, again, excellent detailed anatomy of this bone. And this is the cervical facet joint. And I think it looks like a hamburger. There's the top bun, there's the patty, and then there's a bottom bun, right? And this is where the side portion of two vertebrae intersect and slide against each other and allows you to have rotational and flexion extension movement. And this is that same level that shows you a really abnormal facet joint. So you can see this kind of dense, by dense I mean more white mass that's arising from the facet joint. And this is pretty severe chondrocalcinosis, or mineralization of the joint space and the lining of the joint with hydroxyapatite. And I think and hope that we have some dentists on the call. And you guys would know much better than I do, but I believe hydroxyapatite is also one of the main components of dental enamel. So you can think of hydroxyapatite crystal deposition, like little tiny microcrystals or tooth enamel, basically, in your neck joint. And this is causing a highly destructive, and this patient obviously had right-sided upper neck pain. This is causing a highly destructive facet synovitis. And again, this is something that can be addressed quickly and fairly easily by a surgical washout. But if not detected and left to go on, that can cause destruction of the facet joint, and you could ultimately end up with a surgical fusion. So these again are the types of things that are on almost every cone beam CT that need to be reviewed on, in my opinion, on every scan, just to provide safety for our patients, and hopefully address some of these things before it becomes a bigger problem. I don't want to take up Christine's time, but I think this is let's have this be the last kind of case that we're looking at here. This is a patient with who came in with right-sided facial pain. As we've discussed a few times today, we'll often be evaluating the sinuses and see incidental sinus pathology when we're doing maxillofacial cone beam CT for dental purposes. And this is a patient who has, at first glance, what probably just seems like some moderate mucosal thickening along the maxillary sinus, and then in the ethmoid air cells, extending up to the ethmoid air cells. But we're kind of noting here. So this is the middle terminate in the nasal cavity. That this side should look more like the left side, where you have this nice contour of this delicate bone and the mucosa that surrounds it. And what happened over here, it's not even there anymore. It's like something is pushing through it and destroying it. And this is a case. Let me show you 3 MRIs here of this unfortunate patient. So this is a case of a very aggressive type of sinusitis. And again, we're looking at an MRI where we can see the contrast dye enhancing in normal healthy tissue. So this is on the left side what the mucosa should look like, taking up that contrast and being fed by blood vessels. And over here on the right side, this is all necrotic dead tissue that's being invaded and displaced by this aggressive infection, and unfortunately extending up into the orbit and into the brain. And so this is a highly aggressive fungal sinusitis. So by day 7, this patient unfortunately had a severe progression of this infection and had an enucleation where the right eye is actually removed to try to control this effect, to try to control this infection. And this is a highly feared but fortunately fairly uncommon form of sinusitis called invasive fungal sinusitis. And if it's not immediately surgically debrided, removing all of that dead tissue and infection, there's a very high degree of mortality. And it's fairly common in patients who have poorly controlled diabetes, which is, again, a patient subpopulation that we're seeing in clinic and in our practices. So really important to be evaluating the sinuses on every scan, but looking for subtle clues that, is this run-of-the-mill sinusitis, or is this potentially, is there a little bit of bone destruction here? Is this potentially a more aggressive thing that needs to be referred out to ENT? Let me just, I'm gonna skip through. I have plenty more show and tell here, but I think probably we'll skip a couple of these. Let's come to this one because it brings up another interesting point. I think that a lot of these things that we've been looking at are types of cancer or malignancy or really bad things that we should we should be careful to review and hopefully catch as early as we possibly can. This is another type of thing that we're seeing very commonly on cone beam CT. And you can see this CT scan with this dense ring right here. And this is kind of like that brain CT that we looked at, right? The head CT, where you have a very high density calcification in the carotid artery. And I think Garry referenced, you know, his interest with their organization in pursuing research and validating evidence-based radiology interpretation and care. I'd be extremely interested, since we have such a high number of patients that are getting cone beam CT, and we're most of the time evaluating the carotid arteries for calcification. I'd be really interested to see if we could start to provide a body of evidence that would allow us to score the calcification and risk stratify patients. So if you have an 80-year-old that comes in and looks like this, you know, maybe it doesn't raise too many red flags. If you have a 50-year-old that comes in like this and they have a history of diabetes and hypertension, I'm highly interested in normalizing that against an age-matched control, like they do with the coronary arteries, so that we can risk stratify patients who are at risk for stroke and other cardiovascular events, and get them an ultrasound is a cheap and portable and highly effective method to evaluate the flow in the blood vessel. So this uses a Doppler technique, and it shows you flow is kind of colored in this long, you know, along the length of the carotid artery. And here you can see a critical stenosis. And this patient, if they haven't had a stroke already, is at very high risk of stroke and should be referred to a vascular surgeon to have endarterectomy. So that's the kind of application that I'm really excited about. In addition to, you know, the power of cone beam CT to identify findings in the dentition, is seeing some of these other things that could potentially address burden of disease at an earlier stage for patients. This is, as we kind of cue this up to pass off to Christine, our focus is on a comprehensive review of every part of the scan. The main purpose of that is to keep patients safe and to identify areas of concern, and to help the referring provider identify. If you want a second set of eyes to look at a periapical lucency or a lytic lesion in the mandible, we would love to provide that. But we're going to evaluate every anatomic subsite of the image. And so with that comprehensive review comes a comprehensive report. And I won't read through all of this, but this basically just goes through, as we did in picture form just now, each anatomic subsite, and it's specifically looking for those pertinent negatives. Do I see the normal recesses? Do I see the normal fat plane? And it's talking about positive things that are there that you want to be there, and it's talking about pertinent negatives, things that aren't there that shouldn't be there. And it's going through every anatomic subsection, and then there's an impression. So in this patient who has a lot going on, there's this air fluid level that indicates a characteristic finding of acute maxillary sinusitis, some TMJ arthritis, which I think my dental colleagues, I think, are more familiar with calling that TMD. And in the medical world, I have to get used to that. It's typically referred to as temporomandibular joint TMJ arthritis, but synonymous. A little pericarotid dentigerous or eruption cyst, and then a small amount of vertical impaction on the crown of the mandibular molar, and this interesting kind of bone spur. So each one of those subsites is going to be called out and identified in a radiology, and specifically in DentalRay. Our developers have created a report generator that, as Dr. Siegel referenced, is highly emphasizing a structured templated reporting, so that whether you're the referring provider or a payer and you're evaluating a radiology report, you can easily find the thing that you're looking for is going to be in the same place every time. And every report is going to talk about each anatomic subsite, so that you have the information you need as a provider to help the patient. The patient receives all of the information they can to assess the health of the head and neck. And then I'll leave it to Christine because it's well outside of my wheelhouse to address how that can potentially affect if reimbursement is being sought as well.
Yeah.
So I love being involved in this and love our association with Christine and Eliot and Garry. I love the way that Cone Beam CT is going, and I think it has a very bright future. We would love to help for any who are interested. Keep patients safe and evaluate every portion of the scan. And I'll just say thank you, and that probably can end my part. But I'd love to take any questions, or we can save them from the end, whatever works best for everybody.
We've got a couple questions, Jacob. First one that came in said essentially use an example at the beginning of a patient that could have saved time and cost at the point of care. Do you have an idea of how much money they would have saved if potentially they were essentially taken care of at the point of care that with that dentist?
Yeah, great question. Yeah, I'll let Christine probably has a better sense for the dollars and cents, but I know in one of my hospital-based practices, when you submit a CPT code, so for a CT scan to a payer, if you are submitting a CT scan that was performed in a hospital setting, the amount of reimbursement that is sought is at a multiple of what is sought is if you're obtaining a scan in an outpatient setting, and can be as high as 10x. But there's a lot of obviously there's a lot of differences in the way that insurance companies have negotiated these rates and what they're paying. But there's usually a multiple difference between the amount of payment that is coming for a hospital-based scan versus an outpatient-based scan. And then, insurance is going to cover hopefully the majority of that, but that does affect your copay and your deductible. So if you had a high deductible plan and you were at an outpatient setting, you're going to feel that as if you get scanned in a hospital setting, you're definitely going to feel that as the patient paying a higher out-of-pocket expense. But I don't have a specific number in that case because it does depend on the patient's insurance coverage and the negotiated rates that the payer has with the hospital system.
It also depends on where the scan is taken. So you're going to get less if you're an office submitting scans, or you're going to get a little more if you're an office that's a facility based after being accredited. And there's a lot of factors in it, but for me, after watching that, I think that the amazing thing about a CBCT scan is saving someone's life. I mean, literally. And I'm going to tell you that right now I'm helping an office bill for a patient that they took a CBCT scan on and had to refer the patient out because of something that was seen on the scan. And the patient has carcinoma. But because they caught it so early when they were looking for just something else within the dental world to do implants and overdentures, and the radiologist was able to see that actually is saving that patient's life. And I mean, how do you put a price on that when you really think about what you're doing for your patients? And when you brought up the arthritis and Dr. Brown, when you brought up the arthritis and all that, those systemic conditions are now part of the dental world, period. Because we know patients that lose teeth, that are diabetic, that have other issues. Listen, you could die from diabetes. If you get a sore on your foot, they may have to amputate. And just last week, I taught a hands-on class, and it's amazing to me what you hear when I'm teaching and what I'm learning. is that here was one of the attendees coming to learn how to do medical billing. And what prompted her to do that? Her father is diabetic and he had to have his toes amputated. And the doctor that did the amputation said, you really need to be more conscious of what's going on in your body, whether it's the oral cavity, the digestive system, the sores on your body. And we are part of that. And it was proven by the changes that the American Association of Periodontal Disease made, the changes in how we treat perio patients. And it's like, we have tools that aren't just for our use within the field, but it's to help patients find out what's going on. And even with a sinus infection, we are able to use sinus infection diagnostic codes for treatment within our practice, because the sinus you showed, and correct me if I'm wrong, Dr. Siegel or Dr. Brown, but it does spread. So we now have patients that are coming in with tooth pain, but the tooth pain is not from decay of the tooth, it's from the sinuses leaking into the jawbone, and it's causing patients issues. So I thought that was fascinating because it connects so much more than we even realize. And having somebody read it and then recommend to us, like refer them for another test. That, you know, that's all we have to do. We don't have to diagnose them. We don't have to treat them, but we could help save their lives by referring them out. Now, in your recommendation in your letter, do you help them make those choices, or, you know, or the treatment that they're going to provide? How do you go about that? If nothing major is going on, are you just going to then say your impression is, what is the patient's treatment recommendations, or what is your recommendation as a professional reading it to have the patient go further? Because I think that's important for the dentist to have.
Yeah, exactly. And that's something that we've, you know, when I'm thinking about my family members who are practicing dentistry, busy in their practices, maybe they have their subspecialty, you know, and I tell them, hey, there's something wrong with this patient's nasopharynx. I think there's a mass there. You know, we don't want to drop that on the referring dentist and just let them kind of sync with that, because it might not be something that they're familiar with referring out. One of the things that we wanted to emphasize was that every radiologist that is interpreting for DentalRay has a full active license to practice in the state where they're practicing, and so they are local and they have that network of referrals. And we actually, for our radiologists, we have an automated referral concierge. So basically, when a radiologist sees something, they can click a button and it immediately activates our staff members to start coordinating the referral of this patient. If the referring provider, the dentist, wants to be notified first that we're beginning that communication pathway, we're happy to do that. If they just kind of want to be kept in the loop, but they want it to proceed kind of outside of their office, we're happy to do that too and coordinate to the patient's primary medical provider. But yeah, absolutely, we don't want to come back with a medical finding that somebody might not be familiar with and not understand the what to do with that. So absolutely, we have that pathway established, and then our radiologists are also available for an office consultation or a phone call if there was a follow-up question for any finding.
And that's pretty amazing, because the collaboration of dental and medical is very strong now. And especially for TMD, and a lot of our patients come from a referral from an ENT. So we're receiving patients because they've done their workup and cannot help that patient. So we have the same thing. It's referring them out, especially for ENT, which is TMD. And this is part of what I do teach, that collaboration. So you have it built in already. I mean, that's fabulous because that helps everybody. But even with sleep, we can't diagnose sleep. But if we see an airway that is not large enough to accommodate that patient, and that may be why there is sleep apnea, a lot of the sleep doctors want a copy of that CBCT scan to include, so they could use it with between that and the sleep test that they perform to help diagnose this patient with the proper diagnosis of sleep apnea, and then be able to refer them back to us with the ability to make an appliance and bill for it, because we can't diagnose it. So there's a lot of collaboration right now, and I'm so happy to hear about that referral program. And maybe at a later date, we could do a program, Caleb, on how that works for doctors, because that's something that nobody else does.
Sure.
And,
Yeah,
and really is very special part of the program.
Yeah.
Okay. So thank you so much, Dr. Brown.
Yeah, thanks, Dr. Brown. Really appreciate it. So we'll move into our last segment here, guys. Christine, we're going to have you kind of jump in and start with yours. But before you do, you go ahead and get set up if you'd like to share your screen. I'll just ask this question and feel free to chat it in. But curious for those that are attending, how many scans you're taking per month. And I'll be impressed if you actually know the average number. I've had a few practices that I've talked to, they know it right off the top of their head, but this will be just a good mental push-up for you. So I'll give you just a few seconds to maybe type that in, and you can also guess.
Caleb, are you going to share my screen?
Hold on just a minute. Are you wanting to share your screen, or do you want me to share your screen, Christine?
Well, I can't share it, so you have to, I think.
You're a co-host, so you should be
Let
able
me
to.
see. Okay, wait, I can do it. Sorry.
That's okay. Okay, so we've got, just as you're setting that up, we've got a few chatted in. I know you're all different sizes of institutions and practices, but looks like the winner of the day right now is at 70 scans. So congratulations.
Who was that?
They're from the University of the Pacific.
Ah, well, tell them to call me. They're going to get a free half hour of my billing time.
There you go. That's great.
I can't share for whatever reason, so you have to do it.
Okay. Let me just pull up your slides, Christine, just a moment. You did send those to me, right?
No, I did not. Sorry.
Okay. That's okay. If you can email those, I'll get them shared for you.
Well, it's a big file. Let's see. It won't let me share. I don't know why. I can't email it.
It might be easier for me to troubleshoot you through it.
Yeah.
Are you on the Zoom right now?
Yeah.
Okay. When you hit share screen, what message comes up?
It doesn't. My screen does not come up. Your screen comes up.
Okay, if you take your mouse to the bottom, is that the case? Do you see the menu?
Say that again.
If you take your mouse to the bottom, your cursor to the bottom of the screen, do you see a menu that pops up?
A number?
A menu that pops up.
Yeah, I see share screen. I know how to do that, but it
Right,
won't.
right. But when you click on share screen, does it give you a message or does it not allow you to?
No, it opens the box, but my files are not showing. The only thing I have is your screen.
Okay, so it sounds like you don't have, yeah, I think I know exactly what you're saying. Do you have your presentation open on
Yeah,
your computer?
yeah, my presentation's open. I could see it, but you can't.
And that doesn't come up as an option. So actually do this. I wonder if this is the case. So when you say share screen and it pops up and it gives you the options to share,
Yeah,
there's a top menu, basic, advanced, and files.
yeah, but I tried all and it's not coming up. I have basic, nothing, advanced, nothing, files, nothing. Let me try something else.
Okay. No problem.
Christine, are you on a one monitor setup or a two monitor setup?
I have one right now. I'm
Just
on
one.
one.
Okay.
So, and this, I've never really, it says connect to SharePoint. I don't even have that, so.
Maybe if you email the presentation to Caleb, then he can show it.
Yeah, but it's a big presentation. I mean, I can't mail it. I have to share it.
When you say share, you mean share the URL
I
of the
have to share the
website?
link. So I can't share it. I'm not really sure why, because I've always done this. Never had this issue. See, I see your screen, Dr. Eliot, now, but I don't see mine. Do you guys see me?
Yeah, we see you.
Okay.
We just don't see a screen.
Yep.
Okay, I don't know what to do.
Here, I'm going to send you a
I'll
link.
send you the link. That's the only thing I know how to do at this point, because
Do
it
this,
is not.
Christine. Can you do this? Can you exit the meeting and then re-enter? And
I
we'll see if it resets some settings. So we can hold tight while you close out of Zoom and then get back in with the same link.
So I'm going to leave webinar.
So as Christine's kind of coming back into the meeting, there was another question. I was going to hold it to the end, but I'm just going to ask it now. And it goes back. Christine kind of asked it, and it was about what happens next with the critical finding. But there was an additional question. Oh, Jacob, if you could, what are the top 5 or 10, probably just 5, let's start with 5 pathologies that you typically find when you're reading a CBCT scan? Oh, you're on mute, Jacob.
I like that Caleb is the Zoom ringleader today. He's the trainer.
Yep.
Christine's back.
I'm back.
Christine,
You
go
want me
ahead.
to claim the host?
Yeah, let me make you host again, just a moment. Okay, try and see if you can share your screen, and if that doesn't work, I'm gonna do one.
Okay, here it is. Okay, got it.
Perfect. It's kind of like, Christine, I don't know if you or your kids went through this, but the original Nintendo, right? When it didn't work, you'd blow in the game. There were certain things that you did, and then the Nintendo would just work.
I don't know. Don't ask me. I'm kind of in Dr. Brown's category. I know what I know, and I know what I don't know.
Yeah,
And Zoom is one of them.
yeah.
So
J-
I do it, but it's not my favorite way of teaching because I
Sure.
don't really get the whole thing. But anyway, everybody, sorry. Everybody is afraid of Medicare, and I just want to know why. Is it because they hear all these horror stories about the money, or is it the horror stories about auditing? I don't know, but I could tell you that the world is going to audit you, whether you bill medical or whether you just bill dental. And I could tell you that Medicare has made a lot of advances for the dental world. And the first one was in 2014, which stated, for purposes of the provision, the term physician is limited to doctors of medicine, doctors of osteopathy, doctors of dental surgery, or of dental medicine. So they added us in 2014 to be providers within the scope of our license, which was a very large step, because from the 1800s, when Maryland University Medical School said we're no longer going to have dentists in here, we became separate entities, which was really not the right thing to do. And then another section of the Obama healthcare law was listed, and it states that federal healthcare law states the following: providers, a group health plan and a health insurer offering group or individual health insurance coverage shall not discriminate with respect to participation under the plan or coverage against any healthcare provider who is acting within the scope of that provider's license or certification under the applicable state law. So really, your state law can actually help push what you do in your practice that is medical in nature. And that is one of the big issues that comes about when dental offices try to start medical billing, and they call an insurance company and they speak like a dentist. And what do I mean by that? They're asking the medical insurance, I need to place bone grafts for a patient because they need implants. Is that covered? They're going to say no. But if you look here, a dentist performing a bone graft bills the same exact procedure code as a plastic surgeon performing a bone graft, or an oral surgeon who's reconstructing the patient's jaw when they are in an accident. So we really have the license that we are provided within our state that gives us the liability for those procedures, and who else is going to do it? So we have that to back us. And the following types of providers require the education in many ways for certain treatments within our practice. And we are either going to be an independent diagnostic testing facility, a freestanding imaging center, an office-based imaging facility, a physician's or a non-physician practitioner. And in some cases, we are suppliers of advanced diagnostic imaging purposes for procedures, for purposes of more diagnostic capability. So remember that it's how you set up your practice that's going to determine how we can bill and what we can bill, but you are able to become a medical facility, because it's just like sleep apnea. When you join Medicare, you're not really billing Part B for sleep apnea. You've become a durable medical provider. Your office is dedicated to supplying the appliance to the patient. You're not treating sleep apnea. You're supplying the appliance that the sleep provider is ordering. So we have to remember the ordering purposes and the type of treatment that we can provide and why we provide it. So the key workflows when I'm teaching the billing part is the radiology report coming from somebody that can actually help you. One, the question of liability. Who's liable for reading that report? Well, I'm going to tell you that when I go into a practice or I'm helping an office bill, they bill more successfully when they're having the radiology report read by a radiologist, because the information in there helps you determine your treatment plan, which also helps you determine the diagnostic reason for doing the treatment. So that's a big component. But you are responsible for ordering that CBCT scan, whether the patient is in your office and your patient, or that you're using your CBCT scan for actually another business for people to send in patients. And a lot of offices do that. And a lot of doctors, ENTs, for instance, may not have an available CBCT scan for their use in their office and may refer to you, but they have to come with a written prescription. And that is important for you to have within your own practice. You need to write a prescription as to why you feel a CBCT scan is important for your patient. So it's what your clinical notes have documented. And so we're going to learn, how do you look at the notes that are documented before your patient comes in and after you do your clinical exam. That's very important on how do you refer the patient for that CBCT scan. And then you send your report that gives your dentition report. What are you looking at? And if this patient, which I'm so excited about the radiology DentalRay being able to do, is whether you should refer the patient out for more tests or another doctor to collaborate, or can you do treatment with no other indications of problems that aren't going to impede you from moving ahead. And then your billing becomes separated. Your billing for taking the film, taking the scan. I keep saying it's a film, taking the scan. And the radiologist for reading it is actually going to help you bill for the impression, the report, the written report. And what that's going to do for you right now, if you submit your claim out, your scan to be read by other companies, you're paying the company to do that, which is fine, but you have no way of getting it paid then. And what Caleb and Dr. Brown and that organization is doing is going to give you the ability to now recoup whatever you've paid by being able to bill for the reading of this scan. And you can't get paid at all unless you get certified, because if you do, there are certain laws that you may not know about that we're going to talk about. So you may get paid, but 5 years from now, you may be asked to pay back money, whether to the patient or to the insurance company. So either way, you want to protect yourself today, not after you get an audit. But I want to show you that with Medicare, you do not need to be an in-network provider or supplier, which is what you pretty much are by providing the CBCT scan. So let's just look at what's the difference between all of them as far as money goes and some of the rules. A participating provider or supplier, so if you open up a separate part of your practice, submits an amount of $250. Well, everybody, whether they're participating, non-participating, who accepts assignment, or non-participating who does not want to get a check and just paid by the patient. So they allow $200 if you're participating. If you're non-participating and you're going to wait for the check, then you're going to get 100, you're approved for 190. If you're non-participating, with the patient will get back $190 has been approved for the payment of this CBCT or office visit or whatever it happens to be. 80% is allowable. So participating provider will get $160 check. The co-insurance from the patient is $40. So your total payment is $200. If you're non-participating who waits for the assignment, then your total payment is going to be $190. And the difference is coming in from what you get from the insurance company at $152, which is lower than the $160. And the co-insurance is a little bit lower at $38. So you really get the least amount of money as a non-participating who accepts assignment. If you're non-participating who does not accept assignment, that's perfectly fine, as long as you know what you have to do in the office. And that is a teachable course. It's very simple. However, you see that you still get the 190, non-participating, non-participating. The difference again is what are they approved as the total amount? 152, 152. So again, participating is getting the higher amount. However, the co-insurance and the limiting charge portion pays you at a higher rate. So instead, the patient has to pay you $66.50. And so your total reimbursement is actually the highest at $218.50. So when you become a non-participating provider supplier, the only big thing you have to remember is if you have nothing with Medicare and you opted out completely and you charge the patient for something that has Medicare, you may have to pay it back because you're not following the guidelines. And so when you do non-participating, you think of it as you really have no obligation to wait for the money. You have no obligation to even get that money. The only obligation you have is to make sure the patient understands that they will get the check back. They sign a form understanding they will wait for their own payment and that they are responsible for paying you. The limitation on all Medicare is that there is a lower amount allowed for anybody out of network. So it's not like you're losing that much, because from 250 to 218, I mean, we write off much more in the dental insurance plan than we ever would even in Medicare. So what you hear may be a fallacy. And there's a lot of myths in dentistry that are not true. But if you put in paperwork to opt out, seeing Medicare patients and not knowing the rules anyway, puts you in a liability area more than if you do the application and become a non-participating provider. Because when you do that and you have a CBCT scan within your practice, there is part of the application that you would do that adds in your CBCT scan. You become eligible for billing that CBCT scan with accreditation from a DentalRay. And that gives you the ability to be able to bill, whether they're Medicare, whether they're Advantage plans, whether whatever, because you know the responsibility and liability of billing the patient and them getting the payments back, or billing the patient for the coinsurance and waiting for the check. So all around, Jan Palmer, who is my specialty Medicare person, can help anybody understand and learn how to read these films. And she'll actually be doing a course pretty soon on this. So we will go over all of that legal stuff. But what is a computer tomography, referred as a CT scan or a CBC study, under the medical terminology? So it really, in this study, the CT scan of the maxillofacial area is obtained. The maxillofacial area includes the forehead, the sinuses, nose, nasal bones, jaw, maxilla, and mandible. And the only facial part of the scan that's not in that particular CBCT scan is the orbit. So why do you need to learn how to read and write all of it? Is because that's what you're obtaining a scan that includes all those things. So by doing that, you really have put yourself in the obligation category of like writing it up or having it read. Now, there are courses you could take to learn how to read it. Absolutely. But that's a decision you have to make. And that, in my humble opinion, it's just like as if you want to place implants. You're going to courses, you're paying to take this education, and you're becoming educated in it. And that's how dentistry has worked. That's how medicine works. If you want to do something new, it's not just buying the equipment to do it. It's training on how to utilize it, and then you use it. And a CBCT scan is not just about taking the scan. It's about all of what we just read there. So understand, when I teach at these courses that are selling CBCT scans, I really, people selling equipment are selling equipment. And they're great people, and they can give you a lot of education. And they do help you learn how to utilize it. But it's up to you, the physician, to be able to understand that you do have obligations when you do these things, and learning how to do it is going to be important. What can you do with a CBCT scan in your treatment planning? Well, implant planning. If you're not billing implant planning, even for medical, you're not billing your stent. You're not billing a before to diagnose. You're actually able to bill for when you place to make sure they're all in the right area. And you can bill for a final scan to make sure everything is healing and everything is fine. But you do need to have those read. The evaluation of the jaws and the face. Well, it's funny because the reason CBCT scans came into the dental world is because of the United States Army has been scanning people that go overseas, go to war. And I think Dr. Eliot could speak on that more because he works with a lot of veterans. And so they have a scan. So if something happens to these people, they could be fixed. And that's really important, because if you get in a car accident and you have to have your jaws wired, I mean, they really are basing their ability to put that patient back together on the symmetrics of your face and all that. But imagine having something that shows them exactly. That's another option. Cleft palate assessment, even Carrie's lesions that have transmitted within the oral cavity. And we absolutely need to look at the transmission of infection, because cavities are an active infection and causes the need for root canal or diagnostics. And trauma could be a patient, which I just helped Bill, falling in her own house, breaking her nose, fracturing her teeth, and needing treatment for both of those trauma areas affected. Bone grafts are very small amount of dental insurances pay for that. TMD actually has a law on the book stating that temporal mandibular disorder is not a dental procedure. And if you don't have that law, you need to get it. And that's where the states come in. The states control 99% of the reasons you can bill a lot of these things within your state. And then sleep apnea. I mean, you could be taking a scan. Orthodontists take scans for a lot of pedo patients, and they're seeing the closed airway in color, bright and shiny. And so what is that doing for a child who's now being diagnosed as a attention deficit disorder? And when you see that there's a closed airway, the collaboration of treatment grows tenfold for that child. Should we treat them for expansion of the airway so that they can have less sleep apnea and probably not need medication for attention deficit? Or are we going to use ortho to help that child? And does that child have temporal mandibular, or the face of the child whose mouth or jaw is not really in the proper symmetrical way? And I have my own nephew who actually, his orthodontist put him in headgear, and that was not an easy thing to watch. So because he was so out of line. So there's a lot of reasons for the CBCT scan and in our practices, and we have the tools that could help us. There are specialty areas, just so you know. Any pediatric CBCT use is got special rules around it. So that's a special entity, and we need to be careful if we're using that for pedo. Oral surgery for implants, bone grafts, surgical extractions, and so many more. I have oral surgeons who do third molar wisdom teeth extractions and actually will not extract without a CBCT scan to make sure that when they are extracting that impacted wisdom tooth, they are not going to impinge on the nerve so that the patient doesn't have that jaw numbness that relates back to that. The other thing they're using it for a lot of is, in order to do bone grafts, you have to be very specific. You have to know the level of bone loss. You have to know whether or not there are teeth left to be savable in that quadrant. And if not, what are you going to do? Which would go back to now, why do you need the implant? So there's a lot of reasons for it. Orthodontics has always used a 2D radiograph, but we are now seeing more orthodontics than ever utilizing 3D scanning. Endodontic has added 3D scanning onto their policy as a standard of care, because they have seen that there are more patients getting endo that end up in pain or have the tooth extracted. And by doing a CBCT scan, they could see if there are other canals, and to do that endodontic treatment which includes all the canals and whether or not the disease has spread more into the jaw. So they are really looking at it as standard of care. And we know that perio patients lose more teeth or have more atrophy and potential loss of more teeth. So we have that responsibility. And then TMD and sleep apnea are big components right now for the use of a CBCT scan. So Medicare has a lot of rules online, and I'm just going to show you some of it, but it is an active code. There are no global concept days that apply. That is why, as a diagnostic school, you're not limited to taking it only to diagnose. In fact, when I worked for spine surgery at Mount Sinai in New York, which think about, you know, the jaw bones or the spine bones, they would never do a surgical procedure and not take a technical component within that operating room before they close that patient. And we should be taking the same type of CBCT scans for us to know that what we did looks good. And then at the end, is it healed and is everything good? So that when we dismiss the patient from our treatment plan, we are confident that we've addressed the issues in full. And they do pay for the bilateral procedures, but if you see, it does not apply to CBCT scan when you're taking the whole one. And they do say the modifiers that tell whether or not you're taking the film, the scan, or you're reading it is applicable. So actually taking the film and submitting for the payment of the scan itself has to be modified, and it must be performed under the general supervision of the physician who owns the practice. So again, your NPI number is part of your billing, and payment restrictions are part of for assistance as surgery applies to the procedure. So we have a lot of these rules and we need to follow them. And that's why credentialing is so important. Radiology service paid separately when provided integral to a surgical procedure that's on the list of treatment. So we should bill for the radiology taking of the film and then bill for the reading of the film. And you're billing it at two separate times and entities because the taking is today, but the reading may be tomorrow and your answer may be tomorrow. And we really have to look at that in what are we going to do and treatment plan this patient with. And sometimes dentistry wants everything done today. And we have to look at, sometimes we just can't give the answer to the patient today. So if you want to participate, Jan Palmer again is my go-to person. You could contact me. You could go to my website. She's right there. But if you would like to enroll as a participating provider or a non-participating provider, she could help you fill out those forms and help you make sure you know which one you want to be. And you may not legally collect any money from a Medicare beneficiary, a patient, if you have not declared a status with Medicare, which will also rotate into a lot of the Blue Crosses and now a lot of the private insurances, because they have more Medicare Advantage plans going than even Medicare has. So they've brought in their scope. So if your CT scan is a medical necessity and the providers accept Medicare assignment, Part B will cover it. Again, you might need prior authorization to see an out-of-network doctor if you have an Advantage plan, or you're going to a non-participating provider. But our offices that are being trained in medical billing are learning how to get that pre-authorization even before the patient comes in, with questions and answers that we could obtain on the phone or when making an appointment, so that we could be ready for them on that first exam or that exam visit to be able to take a CBCT scan. So all radiology services require proper orders. So whether you're taking it for your patient in the office or not, you must document this prescription. So I'm going to recommend that you actually have a prescription that can go right into your patient's document center. I have made one that you can use so that you always have everything ready, and it makes it easier as to why you're diagnosing and wanting this imaging. Rule out or possible will not work for reimbursement purposes, because professional services cannot code unconfirmed diagnosis. However, when you're going to take the CBCT film, then that will include signs and symptoms of a diagnosis, because the reason we're taking it is to come to a specific point of treatment and diagnostic reasons why this service is so important. So our patients can call your office and say, you know, I woke up with a lump and I've been in pain for 3 days and I really am having problems chewing on that side, or, you know, I've had headaches, or I'm very drowsy, or just in pain. Those are signs and symptoms. Signs and symptoms are the only thing we could go by for sometimes a test, even in an emergency room. When a patient goes in and they fell, and I use this analogy all the time, and their knee is swollen, all they can say is that I need to be seen because my knee is swollen, I fell on it, and now I can't stand on my leg and I don't know what it is. And so a medical doctor that's doing a clinical at that point, well, he doesn't have X-ray vision either. He may know in his mind, maybe it's a fracture or maybe it's the meniscus, but I don't know for sure. So I'm going to order a CBCT scan or an MRI or an X-ray so I can help diagnose this patient to the fullest extent. And that is how you have to think of everything going on in your practice. Why are you using an X-ray? What's the reason? So you could help diagnose what treatment that area needs. Why is there inflammation? And when you look at the clinical part of the patient, do you really know? Sometimes we don't. And if you don't know the patient's medical history, you're losing out on a lot of clues for treatment within your practice. So diabetics, heart patients, kidney patients, liver patients, 1,000 different things are even paid now for more perio treatment under dental. And we're still not learning how to do that. And we must do that much more often. So remember that it's a tool. It's really just a tool. It doesn't replace the treatment. It just gives us the ability to show a patient and help a patient understand what's going on between the results of the CBCT scan, what you get from information from your patient, the signs and symptoms of why you're taking that CBCT scan. You must update your medical history every single time a patient comes in, and never ask the question, is everything the same? Because I don't know anybody that could remember what they told you the last time they came in. And we all, as every day goes by, things change in our body, and we may be diagnosed with things or may have things that we just don't remember we didn't tell you. And I say use teledentistry more. I'm finding that the offices that are using teledentistry are getting much more information from their patients because it's a visual communication and back and forth, and more patients are giving us the information we need, not just to pre-verify or pre-certify insurances, but to actually get an idea of whether we're going to bill dental or medical. And that is powerful. So the clinical value of a CBCT scan and the imaging program is, why are you taking that CBCT scan? So knowing your patient's reasons they give you and taking your clinical gives you enough of a reason to order the CBCT scan. What is the outcome of that CBCT scan? If you've learned how to read all of this, that's great. Then document it. But I know that most dentists, I hate to say this, do not document why they took x-rays and what the x-rays show. They just tell the patient, this is what you need, but never why you need it. And this is a whole different type of rationale and why, what you do, what did you see, and why do you need this treatment? And that's the benefit of a radiologist, helping you, whether you use them for a short amount of time or forever, or, you know, learn from them. Those are the differences between fixing and helping patients become diagnosed. And that's where you can save lives on every arena. I want to show you a few insurance companies that, you know, they have everything right online. You could go look at it. So an example of Cigna, they allow CBCT scans to be taken, and the CT scan uses those images to show what Dr. Brown talked about, a little bit of everything, and can help the patient understand what is going on. Is it from my teeth? Is it from the bone? Is it from sinuses? And what is it really doing to me? And everything about it. It is a providable and medical necessity under the world of Cigna. Here it is. This is United Healthcare policy. They have the same ones. I'm just giving you different insurances. And it said they added this rationale in 2021. And I actually worked with the doctor that did this, Dr. Tidell from University of North Carolina, and added language to indicate cone beam computed tomography, CBCT, is proven and medically necessary as an adjunctive advanced imaging for complex clinical conditions, oral surgery, implant placement, endodontics, when additional detail is needed to safely render treatment. Removal language indicating CBCT scan should not replace traditional dental radiographs as a preliminary diagnostic tool or for routine dental procedures such as restoration, but be used as an adjunct when the level of detail that is needed to render any complex or clinical condition. Again, they named it. These procedures may have higher risk of complications without level of detail from a CBCT scan. And imaging used for these reasons should be read and interpreted by an appropriately trained professional. So they're actually saying to you in a different language than Medicare, you must be credentialed and you should be using a professional to read the scans. And it's in it, what happens if we do it and they ask us then for a copy of the scan result? They're never going to ask us for the scan like dental, it asks us for x-rays. No, they want the written report. So they will, somewhere along the line, come back. So Blue Cross has pretty much a similar plan. They actually even added more diagnostic procedures. And it doesn't mean that they will pay for some and, United Healthcare will pay. The point I'm trying to make is that it's becoming standard. And diagnostic x-rays, tomograms, arthrograms are all considered medical necessities. Computed tomography scan, magnetic imaging are all pre-surgical evaluation tools. SEPs of x-rays of jaws and skull, panograms, x-rays of maxillary and mandible, and they should be reviewed on an individual basis. It means, again, that we have to be documenting it, not as what we took, but what we saw within those scans. So the key point for all of this is it's the responsibility of the healthcare provider to acquire information data from the patient to best determine the health of patients, and if treatment is indicated to provide this for informed, and you must have informed patient consent. The use of CBC for dental treatment planning poses a situation in which the additional data in the acquired image that are outside of the scope of the primary dental concern could detect systemic conditions that possibly have direct influence on the overall health and longevity of the patient, as you saw when Dr. Brown talked about that sinus infection. Well, we could do treatment on that patient, but if he dies, it doesn't really matter, right? So our obligation, again, is to refer these people out. And if you know what your responsibility is in compliance, just regular dental compliance, this makes 100% sense. In other words, if you're a GP and you have not taken additional courses to do 3 canal, molar, endo, the reason for referring out is because you are not an expert in that, and you do not want to be, you don't want to have a malpractice suit. You don't want to have a possibility of it. So you don't just leave the patient stranded, you refer them out to a specialist. So that's the point we're trying to make. We are not referring out because we don't want to do treatment or we don't want to read something, but we're referring out because it could help that patient in so many ways. And that's why we went into medicine, whether you like it or not. Patients can make informed decisions about their health or dental care and treatment with this report. And it's a component of the informed consent is standard of care. Who performs the report may not be as important as to, or not a report is actually performed. Well, who documents it in full doesn't mean that if you're not trained on documenting it, you can't, but you have to be trained. And the quality and accuracy and the use of the report are subject to scrutiny, and knowledge of such issues determine whether or not a primary provider or a secondary radiologist reader evaluates the image data and issues the final report. This is the big reason that the 3 of our companies are working together, because there are a lot of reasons that the 3 of us should be important within your practice. So what are some signs and symptoms that patients, have a problem with? Well, difficulty swallowing sometimes is a sign of patients that have lost many teeth or have a lot of atrophy or atypical facial pain. They just say they have face pain or they have headache pain. And Botox is an acceptable treatment within the dental practice in many states for TMD. And most patients that have that problem that need Botox rather than an appliance are giving you different symptoms of pain. So they're saying pain in the face, but once they start with headaches or things like that, they may be a Botox patient, not an appliance patient. So there are different things. They also may tell you they're taking certain medications and their mouth is having difficulty swallowing, or they're very dry. And that could come from medications they're taking. And there are codes that are actually consistent with certain medications that affect the oral cavity. And I can tell you with COVID, there are more patients coming into dental practices now that had COVID that are losing teeth or are getting atrophy and don't know why, and or patients that have been wearing masks for 8 to 9 hours a day, breathing in the carbon dioxide and having dry mouth, and are coming up with bleeding and loss of teeth and decay and so many other symptoms that we need to follow up with. And any trauma in the area of the oral cavity, face, lips, any of it is medical billing. And why would you not want a CBCT scan? Because sometimes pathology on X-ray doesn't show trauma, and sometimes it doesn't even show on the CBCT scan. So trauma is unique in keeping that case open. And we talk about cases when you're doing a case. We should be documenting how long should this patient be under our care. Well, the younger they are in a trauma case, the longer they should be in your care. If you're doing implants and bone grafts, well, how long should they be in your care? You know, our follow-up is as important as the starting point. So let's do that. So writing your notes. Well, why is the patient coming to your office? We usually ask that, but then ask them medical questions, such as, are you taking any medication, or are you being treated by a medical provider for any systemic issues? And we could go over the list of that. Ask for permission to contact their medical provider, to collaborate and obtain their medical diagnosis. Not only will it help you in getting pre-authorizations for CBCT scan, oral DNA, or even the treatment you want to provide. It is a unique way of practicing within our field at this point, and opening the doors to doctors referring to us. So having an ENT refer to us, having an OBGYN refer to us, endocrinologist refer to us. Well, guess what? That's the way we're going. And that's why it became a medical necessity. So all those issues are coming into fruition with your scan, with your oral diagnostics, the other tools, the saliva, the testing of saliva, the oral DNA for so many tests, and the ability to do the COVID injections, the ability to do the saliva tests for COVID, the ability to do much more coming up, because I already know. Ask for permission to contact their medical so you can try to maximize their benefits. Who doesn't want to help you maximize benefits? Come on. And get a pre-authorization even before they come in the office. You must write your notes with the subjective. What did the patient tell you? The objective. What is your objective? What are you going to do when this patient comes into your office? Did the doctor order a CBCT scan after you gave him the subjective? The assessment comes after he does his clinical. What's the total assessment of this patient? And then after you receive the results from the oral diagnostics, the CBCT scan, is when you do a plan. I would really ask you to think about this, because dentistry has been look and fix. We look in the oral cavity, we see a fractured tooth, we take an X-ray, we fix it. We've never given our patients the perspective that we are medical, because we've never treated them in the way medical does. And by starting to do that, I'm seeing more and more offices retain more patients for long-term, have more patients referred to them from the medical world, and then have more patients talk about the way we're not looking at their teeth, but we're overall looking at everything about them and helping them stay healthier longer. And I could tell you that the baby boomers, like me, have really mandated this. We are the ones that were interviewed from CMS onto what we wanted coverage for, because regular Medicare never covered a lot of the services we need when we get to a certain age. So our oral cavity and hearing never got covered. Now we have the option of adding those services on. Yes, do we pay for it? But we worked our whole lives, and now we want to have some fun and enjoy life. And we finally have the ability, after raising our families and spending money on kids and college and weddings, we want to stay healthy because we want even more out of our lives. And I think we deserve it. So the following codes that are most commonly billed under the OMS ruling: oral surgery, radiology exam, temporal joint, open and closed, bilateral, the Ceph for orthodontic, computed tomography, maxillofacial area, always without contrast. We don't do contrast in our dental offices. If you need contrast, they should go to a facility that could perform that. If you open a facility, then you should be having someone available to do that, but most of us don't. Radiology exam, single plane tomography, other than without certain things, and radiograph examination, complex motion, body section, mastoids, or whatever. So those are the most common oral. So what's the most common in most offices? I could tell you that most offices are using 70486, but they're not reading all of 70486. They're reading only what they want to treat. And that is not okay. So what do you include in your report, and why not send it to be read? So I took a report, and I'm just giving you what they wrote. So, write up why you need the report. You have to send the report as a prescription to the radiologist so he could read it. And the study purpose for this patient was an impaction. So the CBCT scan showed elongated right condyle, short condyle, root out. Patient reports no history of pain or injury. So the dentist documented what he did say and why he's referring the patient for the CBCT scan, whether it's in his office or whether it's being sent out. Doesn't matter. Dentition, unerupted teeth is what the radiologist now read from the CBCT scan. Unerupted teeth, number 18, 28, 29. I don't know why 48 is there. I must have probably was 32. I'm not sure, but I apologize for that. Occlusion, there is a left side subdivision class 2, which is giving you an important aspect. If you were going to do anything for implants or bone grafting, you must know the classification in order to be able to bill for it. So that is an important aspect. The dental midline and the mandible are shifted to the left. There is a small anterior open bite. Airway, the dimensions of the airway, so they're within normal limits, so you don't have to worry about sleep. The sinuses, yes, we need to know about sinuses in the dental world. It is a direct correlation, and sometimes even ENT can't see something he can't see, and they may be referring to us because of our CBCT scan and a collaborative treatment plan. So think of it that way. Nose, no abnormalities, but he did write TMG, the component that the left side is small, the reduction, and the posterior slope. And so you see everything. Would you change your treatment plan? Because he was just really looking at extractions. So maybe this patient needs more work. Maybe that would be the referral or the impression from the radiologist. I don't know, but that's something that only Dr. Brown and Dr. Eliot are qualified to say to a doctor, I'm not, you're not, and the doctor may be, but wouldn't it be great to have that? So what's the impressions? An adolescent form of degenerative joint disease, progressive condyle resorption is noted on the left and normal on the right. So is that normal? I have no idea because I am not a radiologist. The results in the loss of articular tissue, there is no radiographic evidence of active PCR. Personally, I don't even know what that is. So maybe Dr. Brown or Dr. Garry could jump in and tell everybody what that is. And increases the probability of a displaced disc in the left TMJ. So could you really only treat this patient for surgical extractions? So looking at all of this, how does a GP or even an oral surgeon make this decision on how to treat and what to treat with no other collaborative input? Anybody? Dr. Garry, Dr. Brown, anybody want to jump in? Nobody's there. Okay, so another way of looking at it, and this is how it's written out. So you have an example of how everything is written out, but you don't only have to bill for the diagnostic procedure. You should be billing for an encounter for the surgical aftercare. So you're not billing for an office visit, you're actually billing for the aftercare. Is everything healing okay? That may be the only reason a patient comes in, but that's an important reason. You did surgery, you did treatment. Is everything healing? And that's what we have to be looking at more and more. That's another habit dental has that medical does not have. If you're doing oral DNA and then you treat the patient, are you following up with an oral DNA to see if the patient got better? Well, that's concept of diagnostic tools. We need to be able to justify the treatment. Is the patient getting better? Do we need to make some tweaks in helping them heal? Do we need something else? How do you know they don't? So those are the things. The billing process, you can see I've converted the codes from dental to medical and how you are able to bill for it. But I just want to show you here the dental code, this capture and interpretation with field of view of one dental arch in the mandible. Actually, the TC component is for the capture, not the interpretation. So if you took a film and you're not interpreting it, you're only supplying the component of the scan so it can be read. You're going to use two different diagnostic codes, but the dental world has really made it more confusing because you have two separate codes altogether. So dental made it two separate codes and medical made it one code and conformed it with the ability to say, I'm going to bill as the supplier of the technical component, and the radiologist is going to do the professional component. Now, the radiologist is not subject to the accreditation of the machine, but they are subject to accreditation in their own right. So don't take this wrong, because I want to make sure that you understand, for you to bill the taking of the film, the accreditation component is very important. The professional component is under radiology. They're not listed under the component, they're listed under radiology, and they have their own accreditation process they have to go through. And so some common codes that are used when usually we take it, and I just wanted to go over this, but if you take the CBCT scan on the same day you are The professional component, certain procedures are a combination of the physician component and a technical component. When the physician component is reported separately, it must be identified by code 26, which is saying, I did 2 things in one day on this patient, and I only did the technical component. So modifiers in medical billing are important. I just want to show you a combination of codes that were billed out to an insurance company and how much money is, ended up covered, and what are the benefits of people having radiology is giving you the ability to document the medical necessity for each one of these treatments. So you're looking at implants, bone grafting, surgical extractions, and some other treatments, and you have the ability to do that. But you really can't document a lot of it, medical necessity, unless you have information that gives you medical necessity. So one of the places that you could go to, which is free, is called fairhealthconsumer.org. It is a website patients could go to and look at where can they go to have a CBCT scan for their face, head and neck. And as you can see here, this one is out-of-network doctor that performed the CBCT scan, and it gives you the typical charges of that as an out-of-network provider. If you're in, so by taking it, you're receiving this amount of money in the 90th percentile. So the providers charge it at the top of the list, and the typical plan pays at that 90 percentile. The reading, the medical procedure, not taking it, but the reading of the film usually is about $279 or $175. It could be anywhere because everything is mandated by the zip code you're in. So that's why I like using fairhealth.com. You put your zip code in, and then the typical plan, again, at 90%. So the out-of-pocket for the patient is $28 for the reading, and the out-of-pocket for taking is higher, $416. So we have codes to look at, codes, place it, whether it's taken, read, and so on. So you really have that choice. Again, here is one for the soft tissue part of the scan only, because a lot of my ortho doctors will look at the soft tissue in the CBCT part of the scan, specifically for patients that have typical sleep issues for children. And so here you could see at the 80th percentile, the average billing was $225. And at the 70th percentile of payment, the average fee was $158. And the patient's out-of-pocket cost was $67. So he separates the two sometimes in getting the answers for this, or could take a full CBCT scan and do both. Everybody is a little different.
Hey, Christine,
Yes.
sorry to jump in. Just wanted to time box this a little bit. I think we're nearing the 12:30.
I'm gonna finish right now.
Okay, sounds good.
So they could ask questions. Again, I'm giving you what the California Part B physician fee schedule looks like. Fee schedules for Medicare are right online. You can download them anytime, but when you're looking at the code 70486, what's the typical charge? What's the limiting charge? And then what's the average fee paid? And then the technical component, if you break it up, the technical component, the taking, the 26 is the reading, and the typical payment. So you have the ability to see all that. The accreditation is to meet the requirements of compliance we really have to get up to speed with compliance. And there are so many of the dental practices being looked at right now. It's overwhelming. I don't have enough time. I don't have people to refer these doctors to. And believe me, everybody that does compliance is busy. And that's a sad state of affairs. So you want to be able to do a lot of these things. And yes, you may want to be in network. However, if you want to be a certified coder, which gives you the compliance part of medical billing, the tests are online, the books are approved by the AMA, which gives you a credential under the medical world. This is where we are looking at. And I want to offer everybody a free book. So you're welcome to download our manual. And when you go onto my website, you're just going to put in free guide 22, choose the CBCT scan, and you'll be able to download the CBCT scan. So that is my presentation. So please feel free to contact me, Caleb, Jacob, Eliot, Garry, anybody you need to help you with anything you did not understand.
Thank you, Christine. And that was a very generous offer. I'll definitely say her book is phenomenal. I was reading it the other night, and tremendous way of compiling all the information. There's a lot there, as you can see from her presentation. So thank you. At this time, if there's any questions that anyone has, feel free to chat those in. I'll be watching kind of the chat lines. There was a question that came in. Christine wanted to ask this to you. And the question is, I can see some patients that have a problem with dental practice asking for and billing medical insurance. How would you address this potential patient concern?
Okay, or that's a great question, but when I face it, I have started to tell patients that our practice has included the wellness component of the overall body, because everything in the oral cavity is connected to the body. So you could go to my site and actually download a picture of a body, and it doesn't have a face, but it shows you everything that the saliva and the oral cavity, any infections in it affects our whole body. And that's how diabetics really are very important in the medical billing part of the world, because we know it's an epidemic. And we also know that oral care can't prevent diabetes, nothing can, but we could help patients live longer with diabetes by keeping the saliva in their oral cavity at a pH level that is more acceptable. So we are medical if we've studied these things. And so I let a patient know that we want to help you maximize your benefits, both dental and medical, in any way we can. So will you help me? That's a conversation I have with a patient. I've never had anyone say no to me, ever. In fact, I have patients emailing me for a doctor they could go to that will understand how to bill medical.
So I think it's important context for everybody to know, Christine. Not only are you one of the foremost medical billing experts for the dental industry? I mean, you've been doing it for a long time, but you've also worked in multiple dental practices, managing the office, the front office, the back office, the whole office. And so, I mean, these are conversations that you've had over and over and over. Christine's husband, Paul, who's just tremendous like her, he's actually a dentist. And so they've worked hand in hand with a lot of this stuff. So.
Well, thank you, Caleb.
Well, I don't see any other questions that have come in. If there are questions, of course, reach out to us, like Christine said. I'm just going to close this off and say thank you to our panelists and our speakers. Really appreciate all the preparation. I know this was a long course here, so really appreciate everybody's attention and questions and thoughtful discussion, or allowing us to thoughtfully discuss it. And I just want to say this. I mean, I think it's important. We kind of started with why but I want to end with why. And the sentiment was kind of shared throughout, but I want to underscore it. And that is the thing that's most important for us. And I think I can speak collectively for those that are attending and taking this course, is the overall well-being and health of our patients. And when we think about, when you add in accreditation and you add in the interpretation and you add in the medical billing, it's actually a very powerful thing to think about, that you want what's best for the patient, right? But in order to do that, there's boxes that you want to make sure are checked. You want to make sure that it's done in a safe way, right? Yeah, that's what accreditation helps with, that the safety, you're doing it thoughtfully, and you're doing it from in such a way that someone's saying, yep, that's exactly how you should look at it, or kind of set things up for yourself. And then when you think about the importance of economic viability, right? In order for you to do this, I mean, it takes time to do it right, to put the patient's health first. And so there needs to be appropriate compensation for that. And so this medical billing portion is extremely important, where, dental insurance may not reimburse at appropriate levels, and there's a greater opportunity to do that medically. And of course, obviously, with the interpretation, being able to put the patient first, and we're taking, thousands and thousands of scans every single day, and for the opportunity to be able to really capture through safety overreads, critical or incidental findings that can change a patient and a family's life. So it's an absolute pleasure to be able to share this information with you, and we feel so strongly about what we're moving forward and how we're helping the industry to progress in this manner. So thanks for everything, and we'll leave it at that.
Thank you.
I just need to add one thing in. If the doctors that are online or anyone, PACE credits are given for this 3-hour course. So you will get 3. If you've been on until now, because I didn't say it at the beginning, you can email me your information and the AGD number if you have it, and your PACE credits will go directly in. And if you don't have an AGD, then the paperwork will be sent to you and you have your certificate. So all doctors or anyone that needs the PACE credit is welcome to email me at Links to Success or Taxin at Links to Success. Please feel free to do that, and you will get your PACE certificate.
Thanks. And could you repeat, if somebody got on late, how they can access the recording of this session?
Yeah, well, after today, we're going to download this, and we're going to send it both to Garry to put it on your website, Dr. Eliot, and Caleb to put it on his website, and for myself to put it on my website. So everybody could review it again, or new people could take it again. So those are the benefits of this. And as Caleb so nicely said, our goal is the patient. You will get so much more from patients that know that you're treating them for them, not for the money. And that's the difference between billing medical and billing dental also. Dental is a rebate plan, medical is a necessity. And so justifying it is going to help you show your patients that you are providing these things for reasons above and beyond whatever you used to do. That's what I have to say. So
great, thanks.
Thank you.
You too.
Okay. Well, thanks, everyone.
Thank you.
Thank you, everybody. Great time. Us nerds.
Thanks a lot.
See you soon. Should I stop the share so it could I'll stop it by tonight. You'll have a recording.
Okay, sounds great. Thanks, Christine.
Okay. Good
Thanks.
night.